Morning, ma'am. Can you hear me? Hello? I think it should be okay.
Yes, sir, you are audible.
Uh, Morning, ma'am. I cannot hear you. Hello?
Sir, you're audible, sir.
Yeah, thank you. Thank you.
Good morning, everyone. Welcome back to day 2 of ISPPD Rapid Review Program, organized by Indian Society of Periodontics and Preventive Dentistry and hosted by Department of Pediatric and Preventive Dentistry, Royal Dental College, Chadisheri.
For 1 minute.
Good morning, Dr. Anjana.
We'll start, sir.
Yeah,
We're starting. Yes, sir.
we can start the meeting now. Good morning, everyone.
Morning, sir.
Good morning, Dr. Varun. Thank you for agreeing to be our speaker. Thanks a lot. I'm Virender Goyal. I'm the secretary of our association. And I was not able to join before because we had a family emergency. But today I got free. So I joined this meeting today. Thank you once again, Dr. Venk.
Thank you.
Thank you, sir.
Thank you, sir.
So shall I share my presentation?
Kavya, you can start the meeting.
Yeah. Dr. Varun, I think Dr. Kavya will introduce you and then we can start your presentation.
Yes,
Sure,
sir.
sir.
Let's begin our today's scientific session. Our first speaker for today is Dr. Varun Venkatragavan, Associate Professor and Head of the Department of Medical Genetics at JSS Medical College, Mysore. Dr. Varun has contributed extensively to academics and research with numerous publications and scholarly works. He is a member of several prestigious international genetic society. His area of interest include neurogenetics, skeletal dysplasia, cancer genetics, dental genetics, and immunogenetics. We warmly welcome you, sir.
Thank you. So shall I share my screen?
Okay, sir.
Just a minute. Can you see my screen?
Yes, sir.
Yes, we can hear you. You just need to make it full screen. Yeah, wonderful. Thank you.
So now is it fine?
No, before that, yeah, now it is fine. Now it's full screen.
Achha, right.
Again,
No,
it's gone
again
back.
it went to,
Now?
yeah, it's okay. Now it's full
Okay.
screen.
So good morning, esteemed teachers and students who have come to attend this class. Hopefully, I try to give more perspective on genetics. So, I'm Dr. Varun. So, we'll start our presentation. These are the frequently repeated questions. As you see here, we cover them one by one. So, these are the chromosomes of the human being. We have to realize there are 23 pairs of chromosomes. As you see here, I will use my pointer. Please follow my pointer as and when I see the slides. There are 23 pair of chromosomes, of which 22 are called autosomes and one pair is called sex chromosomes. That is XX makes a female and XY makes a male. Whenever something affects the autosomes, it's called as autosomal dominant or autosomal recessive. Similarly, when it affects the sex chromosomes, it's either called X-linked recessive or X-linked dominant. Coming to what is consanguinity, consanguinity can involve various stages where two related people get married. As you see here, this is double first cousins because they are related from two sides. This is the first cousins. This is the first cousin once removed because there are two people here and only one. And this is the second cousin. So, defining what is heterozygous and homozygous. Heterozygous is when there are two different alleles on the same chromosome. For example, this is green and this is pink. But homozygous is when there are two similar, like as in green here, two greens or two pinks. So coming to what is autosomal dominant inheritance, as you see here with the pedigree I illustrate, this is the autosome, it affects the autosomes. As you see here, males and females are affected. When you see that can a female transmit to a female? Yes. Can a female transmit to a male? Yes. Also, when you see here, can a male transmit to a male? Yes. Can a male transmit to a female? Yes. So both males and females are affected. Both males and females transmit the disease, and as you see here, 50% is the risk of every offspring being affected in the next pregnancy. So what is incomplete penetrance? These are characteristics, these are points which you can write in your exam. If this person is affected and this person is not affected and he is still transmitting the disease to the daughter, that means this person has the mutation but is not expressing the disease. This is called as incomplete penetrance. Whereas Variable expressivity, as in seen here, this is Loeys-Dietz syndrome, where you see tall stature in the first generation with scoliosis. Then you see second generation, there is aortic dissection with the same mutation. Third generation, you're seeing there is cerebral aneurysm. And the fourth generation, it's back to tall stature. So the same gene with same mutation expressing as various phenotypes is called as variable expressivity, which is very characteristic of autosomal dominant disorders. So as I said, complete penetrance and incomplete penetrance, basically all these six individuals have the mutation, all these six individuals have the mutation. These six are expressing the same disease, so it is called complete penetrance. Incomplete penetrance is when when you're seeing that three people are affected and three people are unaffected with the same mutation. So coming to expressivity, which I said, when you see this expressivity, you see everybody is expressing the disease in the similar way. But when you see here, which is variable shades of green and white, so you see that there is a variable expressivity, which is very characteristic of autosomal dominant disorders. What is also characteristic is inter and intrafamilial familial variability is also seen. So there could be also this thing called as age-dependent penetrance, where a disorder manifests after a certain age. For those who want to write extra, these are some concepts: haploinsufficiency, gain of function, structural disruption, protein toxic, and dominant negative effect. The eighth point which we want to speak about is the de novo mutation, where the child has the disease, but none of the parent has the mutation. This is called as de novo. De novo is when both the parents do not harbor the mutation, but the child still has the disease. This is also one of the peculiar features of autosomal dominant disorder. And paternal age effect, like when the father is aged above for 40 years, he predisposes his children to have Noonan syndrome or Marfan syndrome. And finally, what is anticipation is this person manifests the disease at 60, this person manifests the disease at 40, this person manifests the disease at 30, and this person manifests the disease at 20. This is called as anticipation because the number of repeats of a specific gene goes on increasing, like in case of spinocerebellar ataxia. As previously I told, affected parent, unaffected parent, 50% of children tend to have the disease, 50% can be normal. So these are the characteristics of autosomal dominant disorders, which you can write in points. Next, I go to X-linked recessive inheritance. X-linked inheritance is of three types. We have the X-linked recessive, X-linked dominant, and X-linked semi-dominant. So if you follow the pedigree again, you see that the female is a carrier. Female either transmits it to her daughter as a carrier or makes the son affected. The son gets affected. So that is the thing key here. Females are carriers, males are affected. When a male transmits the disease, he does not pass it on to his son, because usually males pass on their Y chromosome to boys. As you see in the case of a female, she's again a carrier because he has transmitted his X chromosome to the girl child. So when you see this kind of pedigree, you think of X-linked recessive inheritance, where males manifest as hemizygote because only one X chromosome is there in men. Females are carriers. There is no male to male transmission, as you see in the pedigree. All daughters are obligate carriers who are born to men who are affected. So it can skip generation. As you see here in this, every generation is affected, but you see the first generation, it is not affected. So carrier females have 50% chance of passing down their mutant allele to the child. Same as you see here, sons of the carrier females have 50% chance of being affected. So what is interesting is females have two X chromosomes and male has one X and Y chromosome. So if you see the X chromosomes, the dose of X chromosome is double that of male. So to prevent the toxic effects of X chromosome, there is something called as X inactivation which happens. If there is defect in X inactivation, you see what is called as a manifesting carriers in X-linked recessive disorders. So coming to X-linked dominant disorders, you see the pedigree here and follow my pointer. you see that this female is affected and she transmits it to her daughter and son who are both affected. Here the son is passing on the genes to mutation to his daughters while his sons remain unaffected. While daughters, the female who is affected is passing down the mutation both to the sons and daughters. So these are the characteristics of X-linked dominant. First, there is no skipping of any generation. Every generation is affected. Males and females are affected, with males more severely affected because a male has only one X chromosome. Then if you see, females are transmitting the mutation both to son and daughter, while men are only able to transmit the disease to the daughters and not sons. So this is what is characteristic of X-linked dominant disorder. So when you have a question in the exam, you can classify it as X-linked recessive, X-linked dominant, and X-linked semi-dominant. Semi-dominant is when there are carrier manifesting females behaving both as X-linked recessive and X-linked dominant. Coming to the next question, which is genetic counseling. So basically, genetic counseling is when you encounter a family, when you investigate a family who's affected or at risk of any genetic disorders. So you help the family through various aspects. So you counsel the family, you do what is called as a test. You suggest what tests can be done, you educate the family, and you risk stratify them so that they do not have another child similarly affected within the future pregnancy. So as I said, in consanguineous couple, the chances of genetic disorders are little high. So we start with the first step called community awareness. We make the community aware that consanguineous marriages are not great. Then we educate the family saying why consanguineous marriages have a problem. Then we do what is called genetic testing. Then we do what is called as preconceptive counseling. That is basically the couple come to you before they are pregnant. And this is pregnancy management during the time of pregnancy and postnatal support when the child is born. So,
I don't know how you are listening.
hello. Can you hear me? Hello.
Sir, you can continue, sir.
Yeah, sorry. Genetic counseling can be done into prenatal counseling and postnatal counseling, as you see here. Prenatal counseling, we do what is called as pre-test counseling with what is the diagnosis, what are the possible outcomes. We have to take informed consent, and we have to take perspective of what emotional challenges the patient is going through. Post-test counseling, we have what is called as we have to explain the disorder. We have to inform them of the decisions what they can take and what prenatal options are available, and psychological support is the most important. So similar to prenatal counseling, the postnatal counseling involves what is called a pre-test and a post-test counseling. So whenever you advise a procedure like you usually do, it's the same for genetic disorders where you do pre-test counseling, where you tell them what is the test, how do you do it, what are the outcomes, and what could we expect. And post-test counseling, when you actually tell them what has come across, what are the treatment options, and what are the inheritance patterns, and what is the recurrence risk for the next pregnancy. This is the same thing. Principles of genetic counseling involves diagnosis, risk calculation, communication, and support. So the most important part of genetic counseling is emotional, psychosocial, ethical, and religious concerns of the families, because we live in such a divergent society. We have to be inclusive of everybody, and we have to take into account of all these factors. So the most important factors we will need is a psychologist who can help us with dealing with denial, guilt, hostility, grief, and mourning, because these parents would have lost several children, or they would have had a child with a genetic disorder. So coming to the next topic, which is the genetic aspects of caries. So if you see caries is a multifactorial disorder, as we all know. It can have both. It can have multiple issues. First is the microorganism, which we all commonly know, that is the Streptococcus mutans. The next thing which we come to is what is called as salivary proteins. Then what we intake, then the immunity which we have, the taste receptors, including the taste receptors with those who consume high sugar and those who consume low sugar, there is also genetic predisposition for that as well. So when you come to genes, we have 6 important genes. That is, we start with amyloblastin, calcarein 4, the DSPP, which we will come across again and again, stands for uh, hello. DSPP stands for sialophosphoprotein. This is the amylogenin, and this is MMP, which is the matrix metalloprotein, and this is the tuftulen. So we'll come to it in detail in the next few slides. So basically, it is multifactorial. As I said, multiple risk factors can be there with bacteria which can affect host, diet, and environmental factors. So we can write this for our exam where we see twin studies where they have shown that monozygotic twins have a higher rate of caries as compared to dizygotic twins. So when you see people who eat high sugar are naturally at a risk of higher caries. As you see through the linkage studies, what is called as uh, DMF scoring. So if you see the DMF score, which is the decade missing filled tooth, so if you see a person with a high DMF mother and high DMF father, so he will naturally or they will naturally have a high DMF offspring. So coming to the two genes which are very important, that is the amylogenin, amyloblastin, dentin sialophosphoprotein, tuftulen, matrix metalloprotein 20, calcarein, and enamelin. These are genes very important for enamel formation and maintenance. So they are usually, as we will see in the further slides, they are also involved in amelogenesis imperfecta as well. So taste genes, when you come to taste genes, we have two sets, that the TASIR2 and TASIR3. They are the sweet genes. TASIR38 is the bitter gene. So if you have the former gene polymorphisms, they are caries prone, but if you have the latter genes, they are caries protective. So when you come to immune system, similarly a bias is noted where HLA-DR3 and 4 increase the risk of caries, while HLA-DQ2 is protective because these are all interacting with Streptococcus mutans. So coming to a small flow chart. So when you see genetic variants, we can divide them into weak enamel, where you see them associated with amelogenesis imperfecta, low salivary flow, as in case of MUC5B and ekvaporin 5, that is AQP5 mutation, sugar preferences, as you see in TASIR2 and TASIR38, and immune defect, as you see in interleukin 1B, interleukin 6, and TLR is tool-like receptor. So when you have mutation in that, and there is an environmental predisposing factor, so it pros the patient becomes prone for caries. So the dental caries happens and the heritability becomes an issue. Uh, Coming to the caries prone genes, that is the tooth related genes, they are mostly related to amelogenesis imperfecta, dentogenesis imperfecta, or dental dysplasia. So we have the amylogenin gene, which is located on the X chromosome, which is the most important gene for us in genetics because we use it as marker for many things. So this causes amelogenesis imperfecta. This is the amyloblastin. As you see, it is required for enamel formation and helps in maintenance. So enamel formation defects can be seen. DSPP, you will hear this gene again. That is the dentin sialophosphoprotein, which encodes for the two components, the sialoprotein and the phosphoprotein. Mutations of which are noted in two conditions. One is the dentinogenesis imperfecta type 2 and also dental dysplasia type 2. So similarly, tuftulen plays an important role in initial stages of mineralization. So overexpression causes multiple abnormalities of the enamel. So matrix metalloprotein, you will come across this again. It is called as enamolysin. So it helps in enamel organization and uh, basically the mutations of which again causes amelogenesis imperfecta. This is the calcarein 4, which you see here. It also helps in organization and orderly replacement of organic matrix and mineral, producing harder enamel. So it causes amelogenesis imperfecta. So finally, we have the enamelin, which is the most important gene for autosomal dominant amelogenesis imperfecta. So which we will see in the next few slides. There are extra points which, if you're interested to write, that is we have the gene related to ORAE2, as you see here, OR4E2, which helps in smell. So basically, any person with mutations in this gene can be prone for caries. The next gene is SPRY2. As we see here, it supports the salivary glands. And gender and dental caries are usually females have a higher predisposition in the initial years, which because of behavioral issues, males then take over from the females at a later stage. So coming to the next aspect, that is the dental aspects of tooth agenesis. So we classify as per genetics into enodontia, oligodontia, and hypodontia for convenience. So again, it can be primary or permanent, making them into agenodontia or ablastodontia, oligodontia, oligogenodontia or oligoblastodontia, atlogenodontia or atlobastodontia. So what is interesting is tooth agenesis is some of the most common prevalent genetic anomalies, can be syndromic or non-syndromic. You cannot distinguish between a syndromic and a non-syndromic form many a times because the same gene, as we will see in the next slide, can cause both the syndromic form and the non-syndromic form. The most commonly affected tooth is the third molar. In the primary dentition, however, we see the upper lateral incisors followed by the lower central and the lateral incisors being more affected. So the four most important genes which we have to remember in this category is EDA, MSX1, WNT10A and PAX9. So if you see EDA, this is what is the most important gene for X-linked ectodermal dysplasia. So this is the most common form of syndromic tooth agenesis. So when you come to MSX1, it is a spectrum where the most severe end causes ectodermal dysplasia, while the most least severe end causes only tooth agenesis. So the next one is the WNT10A gene, where it causes both autosomal dominant and autosomal recessive tooth agenesis, but the severe end again can cause ectodermal dysplasia. Interestingly, the PAX9 gene only causes autosomal dominant selective tooth agenesis. So it becomes, it is a purely dental related gene. So again, the list goes on, but I would want you to remember four genes here at least. The LRP6, which causes tooth agenesis, PTX2, which is very important, which causes Axenfeld Rieger or anterior segment dysgenesis, where there are tooth anomalies and ocular anomalies. Then we have the SMOC2 SMOC2, which causes dental dysplasia type 1, which we will come to next. The sonic hedgehog pathway related gene causes holoprosencephaly with most important clinical marker for us, which is the central incisor, which is very characteristic for this disease. If you remember 1, 2, 3, 4 in this list, I think it should do because LRP6, PTX2, SMOC2 and SSH are the most commonly encountered genes which we see in the clinical practice. So coming to a proper flowchart, genetic basis of tooth agenesis can be divided into hypodontia, oligodontia or enodontia, can be non-syndromic or syndromic. Inheritance pattern can be autosomal dominant, autosomal recessive or X-linked. So genetic testing can be done and we can predict whether this can recur in the family and what manifestations can each disease have. For those who want to go into more of genetics, we can divide the genes into the WNT pathway related genes, transcription related genes, and the ectodermal dysplasia related genes. So basically, all of these will lead to the conclusion of tooth agenesis, which can be again non-syndromic and syndromic. I'll make this very simple for you. So PAX9, MSX1, AXN2, WNT10A were considered purely non-syndromic genes, but now we know that WNT10A also is syndromic and non-syndromic. So coming to the syndromic genes which are common, which is EDA, which I said is ectodermal dysplasia X-linked, which is very common. EDAR is basically can occur in both autosomal dominant and autosomal recessive forms. TP63 causes ectrodactyly, ectodermal dysplasia, and cleft lip palate syndrome. And finally, we have the IRF6, which has van der Voort syndrome with characteristic lip pits, which are very characteristic of the disease. So this is a child with ectodermal dysplasia where you see absent hair, no eyebrows, and tooth anomalies including tooth agenesis, dysmorphic features, and nail abnormalities. If you see the MSX1 related disease, you see that this entire family is autosomal dominant. It is affected in autosomal dominant format. So you will see oligodontia and multiple teeth anomalies. So coming to inherited enamel defects and enamel hypoplasia. So enamel is a unique structure with low protein and a high mineral content. 100 known genes are there to be involved in enamel formation. So amyloblast has two main functions for us. One is the maturation. Second is it has four main protein matrix proteins and proteases, which is amylogenin, amyloblastin, enamelin, and enamelin and enamelolysin. So again, amylogenesis imperfecta can be of two types. Quantity, which affects the enamel, causes hypoplasia. Quality, if it is affected, causes hypomineralization with hypomaturation. Mixed forms can also be seen. This is a very exhaustive list, which I think humanly is not possible to remember. So maybe we can simplify it into this category where we have three pattern of inheritance: autosomal dominant, autosomal recessive, and X-linked. So autosomal dominant, we have the enamelin gene. Again, I said autosomal recessive, enamelin can cause both autosomal dominant and recessive disease. This is the calcarein 4, that is the Cal4. This is MMP20, which is also called as enamelolysin. So X-linked, we have the amylogenin. So making this classification more clearer, autosomal dominant, autosomal recessive, X-linked. So autosomal dominant, we have the enamelin, as you see here. It can be seen in both autosomal dominant and autosomal recessive. So we have brought in a new entity with taurodontism, that is the DLX3. Then we have the recessive forms of enamelolysin, that is MMP20, calcarein 4, that is the Cal4. Then we have the X-linked form, which is of two types again. This is the amylogenin, and the second one lies on the XQ22 region, cytoband region. The gene is yet to be identified for this condition. So further, this is dentinogenesis imperfecta. So we have the incidence can range from 1 in 6,000 to 1 in 8,000. Again, dentinogenesis imperfecta is of three types. The type 1 is the most relevant to the systemic manifestation because it is associated with osteogenesis imperfecta type 1, and it is caused due to mutations in the COL1A1 gene, that is the collagen 1 gene. So type 2 and type 3 we have previously discussed that it is caused due to DSPP mutation, also called as dentin sialophosphoprotein. So if you see here, you have to you can clinically differentiate it with multiple features. Probably you would be the expert. But dentinogenesis type 2 and type 3 would be caused due to mutation in the DSPP gene, which is the main candidate gene for two entities, that is dentinogenesis imperfecta type 2, dentinogenesis imperfecta type 3, and dental dysplasia type 2. These are the three entities which the DSPP mutation can cause. So that is what is emphasized here, the same thing. So I would come up with this picture. So if you see here, so these are the genes causing amelogenesis imperfecta. We have the X-linked amylogenin. Then we have the enamelin, which can be autosomal dominant and recessive. Then we have the MMP20, which is the enamelolysin, which is autosomal recessive. Again, leading to various subtypes. Then we come to what is dentinogenesis imperfecta. For us, the main gene is COL1A1, which I said, which causes osteogenesis imperfecta with dentinogenesis imperfecta. The type 2 and the type 3 cause are due to mutations in the DSPP gene. Similarly, when you see gene involved in dental dysplasia, the type 1, which is now identified as SMOC2 gene, which I previously told, and the type 2 variety is usually caused by DSPP gene again. Coming to briefly genetics of malocclusion. So we have etiologically skeletal malocclusions arise from skeletal disharmonies. So we have 6 factors. Basically, this is also a multifactorial disorder with both genetic and environmental factors being involved. We have the skeletal and the jaw growth. Then we have the mandibular and the condylar growth. We have the tooth development and the eruption. Then we have the craniofacial patterning. Then we have the class 3 loci for prognathism. Then we have the syndromic genes. I'll come to each one of them now. So if you see here, the skeletal jaw growth, we have already seen MSX1 with previous discussion. Then we are going to see MSX2, which is involved in skull and jaw fusion. FGFR2 and 3 are basically pathways, growth factor pathways. And we have the RUNX2, RUNX2, which is due to osteoblast, which comes in the osteoblast pathway. So then we come to what is called as mandibular and condylar growth. We have the IGF-1 and the growth hormone 1. Both are involved in various aspects of facial and craniofacial growth. So we see various mandibular anomalies with this. So PTCH1 is what is associated with Gordon-Gorlin syndrome. So and COL1A1 and TGF beta 3 are basically collagen related pathways where you will have osteogenesis imperfecta and Loeys-Dietz syndrome. So both of which can affect the jaw very significantly. Lastly, we have already read about this tooth development and eruption previously, the PAX9, which we have read in tooth agenesis, EDA, which we have read in syndromic tooth agenesis, WNT10A can be both syndromic and non-syndromic. Axin 2 we have already read with tooth agenesis, and DLX 5 and 6 is involved in jaw patterning. The next set of genes which we will be talking of is the craniofacial patterning, where you saw BMP4 and SSH, which SSH we've already seen with respect to central incisors. Twist 1 causes Sutherage-Austin syndrome, which is a craniosynostosis syndrome. This is the Ephrin B1 and Hox A2, which is involved with symmetry. Coming to class 3 prognathism, the most important, if you have to remember, is the DUSP6, which is the most important gene in this loci, as will come in the next slide. So syndromic, we'll have the most common being Treacher-Collins syndrome, where you have microretrognathia, FGFR related fever syndrome, PTPN11 causing Noonan syndrome. The other two being channels and chromatin regulator, that is the KCNJ2, Anderson-Twail, and CAT6A mutations. So mandibular prognathism are specifically caused by mutations in all of these genes. I think remembering them is a very exhaustive list. I think COL2A1 and TGFB3 can be remembered. So DUSP6 is the most important for class 3 malocclusion, which is most common. PAX9, as I said, is most commonly involved in oligodontia as well as malocclusion. And mutations in the MYO1H gene can cause mandibular prognathism and mandibular retrognathism. This is Down syndrome and genetics, which I'll be coming to next, which has been repeated multiple times. So this is the most common anomaly in Down syndrome. This is called as trisomy 21. As I said, each human has 23 pair of chromosomes. If you count this individual will almost have 47 chromosomes, because there is an extra chromosome 21 sitting here. So if you see the facial phenotype of the child, you will see that the child has an upslanting palpebral fissure, hypertelorism, depressed nasal bridge, bulbous nasal tip, open mouth, and a hypotonic appearance. This is very characteristic for Down syndrome. It is caused due to what is called as non-disjunction, when the sperm and the ovum are undergoing meiosis stage 1 and stage 2. They divide equally into 23 and 23 chromosomes each into the germ cells. But sometimes what happens, the 23 chromosomes which has to go into one cell, they will separate as 22 and 24. And when this 24 cells meets the 24 chromosomes meets the 23 chromosomes, then you get what is called 47 chromosomes. And further through mitosis, this cells will just multiply, and this is what is called Down syndrome because the extra chromosome has come from chromosome number 21. So dental abnormalities in Down syndrome are usually they are very common, like maxillary hypoplasia, class 3 occlusion, anterior open bite and posterior cross bite. There could be delayed eruptions including hypodontia or microdontia. So there could be pegged laterals, like there could be relative macroglossia, fissured tongue. There could be mouth breathing, angular cheilitis, severe periodontal risk, and lower caries risk. So coming to next topic, which is Hurler syndrome. Hurler syndrome is the most common type of mucopolysaccharidosis. It is also called as MPS 1. It is an autosomal recessive disorder caused due to mutation in the IDUA gene. So if you see the IDUA gene, it encodes for the enzyme alpha-1 iduronase. Iduronase is required for breakdown of glycosaminoglycans, and specifically it breaks down dermatan sulfate and heparin sulfate. If this action is lost, then you will have cellular toxicity leading to progressive accumulation of glycosaminoglycans, leading to this phenotype. That is, you see that there is mental retardation when there is accumulation in the brain. You see frontal bossing, you see what is hypertelorism, and there is space, there is excess space between the two eyes. Then there is depressed nasal bridge. There is characteristic macroglossia, and there could be multiple dental anomalies. Along with that, you see what is called as liver enlargement, that is hepatomegaly, splenomegaly, and multiple bony deformities, including the contractures of the hands and knees. So, coming to the next topic, that is genes associated with salivary proteins. We have the following genes. It is an exhaustive list, but it is quite easy to remember. We have the digestive enzymes, that is the amylase related genes, that is classified as AMY, 1A, 1B, and 1C. This is very easy to remember because they are named just after the three letters of the starting enzyme's name. So it is required for starch digestion. So we have the proline-rich proteins, which can be either basic or acidic. As you see, it is required for calcium homeostasis, enamel protection, lubrication, and tannin binding. If you see the antimicrobial peptides, we have the HTN1 and HTN3, that is high statins, which is required for Candida albicans, and antibacterial properties. Then we have the cysteine proteases, very easy to remember, CST1 till CST5, excluding CST3. So it inhibits bacterial growth. Then we have the high molecular weight mucins, which are MUC5B, that is the MUC5B and the MUC7. So they are required for lubrication and also help in pathogen prevention of pathogen aggregation, especially the Streptococcus mutans. Then we have the immune system proteins. So immune system proteins, you can just remember lactoferrin. The others you may remember, but important one is the lactoferrin. So it helps in iron chelation and bacterial cell lysis. The last one is the calcium binding protein, also called as tetherin. So it prevents the calcium in the phosphate precipitation and maintains enamel mineralization. So in a quick revision, amylase gene families has the amylin AMY1A, 1B, and 1C. This is required for breakdown of starch and glycogen, the alpha-1,4 linkage to maltose. Then we have the proline-rich protein, which could be either acidic, that is the PRH1 and 2. Then we have the basic, that is the PRB1, PRB2, PRB3, and PRB4. So basically, acidic and basic are required for multiple functions. As you see here, it is required to bind dietary tannins to reduce toxicity and lubricate the food bolus. So histatin 1 and 3, as we discussed previously, is required for fungal. Mainly it disrupts the fungal mitochondrial membrane and is very important against to prevent oral candidiasis. Then we have the MUC5B and the MUC7. We call them MUC5B and MUC7. MUC5B is usually required for lubrication, whereas MUC7 specifically is required for Streptococcus mutans. So basically, clinical significance is salivary markers. We can use them in diagnostics, as you see in squamous cell carcinoma and multiple other tumors. Then we have the We can identify caries susceptibility by analysis of the salivary proteins, and we can use therapeutic artificial saliva in case of radiotherapy prone tumors, especially the oral cancers or the ENT cancers. So this is recombinant DNA technology. So I will discuss this. So basically recombinant DNA is artificially assembled DNA where you join genes from two or more organisms. So what happens is we have the first segment of a gene, which is taken the gene of interest. For example, in this case, you can take the insulin gene. Then you take a bacterial plasmid. Plasmid is basically a uh, it is a circular double-stranded DNA. So basically, you cut the plasmid at the desired site, attach the gene of interest to the plasmid, and make it what is called as a recombinant plasmid, because this plasmid now contains two DNA of two different organisms as defined here. So this becomes the recombinant plasmid. So you put it into the bacterial cell and you let it multiply. Once you reach the target, you lyse all the bacteria and take the product. So it has multiple utilizations, including the research application, agriculture, industrial requirements, medicinal requirements, food technology, and biotechnological requirements. So basically, we can produce insulin, growth hormone, and clotting factors in large scale. We can do what is called as agricultural products, including GM crops, which can have water resistance and drought tolerance. Gene therapy can be used because we can correct the faulty genes in these patients. Then we can do research by studying gene function, we can knock out these genes and study mice, and we can do CRISPR editing, which is the latest. We can study DNA profiling and fingerprinting in forensics. And industries, we can prepare enzymes for detergents and biofuels. Coming to the last topic of the day, that is gene therapy. We have the in vivo and the ex vivo. If you see carefully, what is in vivo is we load the gene of interest. For example, if the patient is diabetes mellitus, he will have deficiency of the insulin gene. So we will load the virus vector with insulin gene, incorporate into the body through either injections or through infusions. So that is called as in vivo, where the body takes the in vivo cell up and integrates it into the system. Ex vivo is basically you take the patient's stem cells, you correct the underlying genetic defect from an outside perspective. So you don't have a viral vector involved. Then you check for the expression of the gene and you put it back into the patient. So this is the two methods, ex vivo and in vivo. So if you see here, we have identified the defective gene, then we can correct the gene. Either we have inserted into the vector, that becomes in vivo. If we have corrected the defect in the stem cells, then we call it ex vivo, and we put it back into the cell where the gene expresses in the cell, and the disease symptoms are corrected. So we can use viral vectors or non-viral vectors. We have the adeno-associated virus. Then we have the lentivirus. Then we have the adenovirus plane. Non-viral methods we can use is electroporation, where you give small electrical pulses into the cell and induce. Then we have the lipid nanoparticles and the gene gun. So most importantly, this would be my last slide. But I would just, since we have time, I would just quickly go through just the genes so that we have a quick recap. Correct. For genetic aspect, for genetics of caries, we have the following genes which we have to remember. That is the amylogenin, amyloblastin, DSPP, tuftulin, MMP, calcarein, and enamelin. So if you remember this, and then if you remember the taste genes, that is the TASIR2 and TASIR3, which is the sweet, and TASIR38, which is the bitter gene. And finally, immune polymorphisms like the HLA-DR3 and HLA-DR4 for caries risk, and HLA-DQ2 for protective risk. So for tooth agenesis, you have to remember these four important genes: the EDA, MSX1, WNT10A, and PAX9. If you can remember these four genes, the LRP6, PTEX2, SMOC2, and SSH, it is a very good thing. So syndromic and non-syndromic also we have already classified. In amelogenesis imperfecta, you have to remember the enamelin gene, enamelolysin, calcarein, amelogenin, and if you can remember DLX3, you can remember DLX3 as well. Coming to dentinogenesis imperfecta, we have to only remember one gene, that is the DSPP. Genetics, again, malocclusion, if you can remember all the list, it is great. But in this, if you can remember MSX1, FGFR2, and FGFR3, which is the most important. In the mandibular section, you can remember the IGF1, GH1, and PTCH1. In tooth agenesis, we already know the genes. We've already studied these genes. In craniofacial patterning, you can remember the twist gene and the SSH gene. In the class 3 prognathism, we have to not forget DUSP6. In the syndromic category, we should not forget TCOF, FGFR1, PTPN11, at least these three genes. These two are less less significantly we see these cases, but we see these cases very commonly. Down syndrome, I have already explained to you. Hurler syndrome is because of IDUA gene, which I have explained to you. Salivary proteins, it's very easy to remember. Digestive, proline-rich proteins, antibacterial peptides, cysteine proteases, high molecular weight mucins, immune defensins, and calcium binding. So I think I'll stop here.
Thank you, sir. Thank you for the wonderful session. It was very informative and enlightening.
Anybody has any doubt?
I hope I was not very quick with the session, and yeah, sorry. It was very fast.
Thank you, sir. Kindly accept the certificate as a token of appreciation for your insightful session. Thank you, sir.
Thank you. Thank you for inviting me.
Our next speaker is Dr. Shabnam Sahib, Professor and Head of the Department of Pediatric and Preventive Dentistry at Guru Nanak Institute of Dental Science and Research, Kolkata. He completed her BDS and MDS from GDC Kolkata and earned her PhD from West Bengal University of Health Science, Kolkata. She is an accomplished academician and researcher. She has over 100 index publications and she is the recipient of several prestigious recognition, including the Distinguished Women Award by ISPPD. We warmly welcome you, ma'am. Shabnam, ma'am.
Kavya, I think I cannot see the Shabnam on the platform. Can anyone call her?
Okay, sir.
And is she presenting live or she has sent a recording?
Live video, sir.
Live. Okay.
Yes, sir.
Then she must be on the platform.
Okay, sir.
Dr. Kavya, I think we are running a little early because her time schedule is 11:15, and maybe that is the reason she is not there on the platform.
Sir, I just inform her.
Okay.
Okay, sir.
Yeah. So whenever we are early, I think we should inform the speaker beforehand that we have finished the previous lecture early, and now we will.
Okay,
Sir, I have joined. Am I
Yeah,
audible?
Dr. Shabnam. Welcome, Dr. Shabnam. Thank you so much
Sir, good
for
morning,
being with
sir.
us.
Good morning very much.
Yeah. Sorry, we are a little early.
Just,
The first lecture
no, it's
finished.
all right. I was on, but I will just share the screen.
No problem, no problem. That's absolutely fine.
Welcome, Dr. Shabnam.
Yes, welcome, Anjali ma'am. So, is my screen visible?
I think you have just started sharing. It is yet to be
So I will stop
displayed.
sharing now. First, I think the introduction.
No,
and
now we can
then
see
I
the
will
good
start
morning
sharing.
screen. No,
Stop. I will stop sharing, sir.
you can start sharing
You
your
can start.
screen now.
We can see you.
Yeah, we could see that cab with good morning.
Yes, sir. Sir, I have stopped sharing. So if we will start the session and then I will start sharing.
Yeah, you can.
Should I start?
Kavya has already introduced about you, and you can start sharing your screen,
Okay,
Dr. Shabnam.
okay.
Yeah.
I will just share it.
Yeah.
Sure.
Dr. Anjana, how's the weather there? I think it must be raining.
So very
It's
good
raining
morning,
heavily, sir.
everyone. Am I
Continuously.
audible?
Yeah,
Yes,
Dr. Shabnam, we
it's
can hear
raining
you.
very heavily. Yes.
Yes.
But now the rain has stopped. But it's quite
Okay.
comfortable. Otherwise, it was very hot. But now it's quite comfortable.
Okay.
Okay. So should I start?
Yes.
But we cannot see your
Should I
screen.
start,
Am I
sir?
right, Dr. Anjana?
Ma'am, should I start? Oh,
Yeah. Start.
you're not able.
Start sharing your screen.
I have shared. Is it not visible, ma'am?
No, it is not visible yet.
It's not visible yet.
Okay, sir. Ma'am, I'll just. Visible now. Is it visible, ma'am?
No.
No.
Now it's come.
Now I think it should
Now
be
it
visible
is
now.
started. It's visible now?
It's visible.
Yes.
Absolutely.
Okay. Very good morning to you all from Kolkata, the city of joy. And I'm really thankful that ISPPD is organizing for the first time the Basic Science Rapid Review. And I should thank our President Balika sir and the Secretary General Dr. Virendra Goyal sir, and of course the Department of Pediatric and Preventive Dentistry, Royal Dental College, Palakkad, especially Dr. Anjana ma'am and her team for organizing such effectively this program and giving me a chance to speak on a topic that is growth and development. So, already my introduction has been given. I am Professor Shabnam Zahid. So, growth and development is a very big chapter. So, I have divided it in three parts, and that is general principles and concept of growth and development, prenatal and postnatal growth and development, uh, and prenatal postnatal growth of craniofacial structure, uh, development of dentition and occlusion. So first, I will be talking about general principle and concepts of growth and development. Now, as because this growth and development chapter, basically this is taken partly by the oral patho department and also partly by us, where we take almost more than 10 to 15 lectures, and that I have to give it in 45 minutes. So I'll be discussing mostly about the frequently asked questions for the first year MDS exam. So mostly we get 10 numbers of questions and you have to finish, it's basically 10 questions of 10 numbers, each 100 marks, and you get 3 hours. That is 120 minutes. So if you can calculate for one number of questions, you are assigned 1.2 minutes. So for 10-minute question, you have to finish it by 12 minutes. So if you know that, so that when you start a question writing, you don't write too much on the first few questions which you know, and then you write less for the question. So you can think about that, because this is a growth and development chapter. Even the questions are quite big, but you have to finish it by 12 minutes. So the first question that I will be discussing is the define growth and development and describe details about the rates of growth. Now, what you can do, introduction, you can give a definition of growth and development. There are a lot of definitions, but I found out the definition by Todd for both growth and development easiest.
Excuse me,
So you
ma'am.
can do that.
Ma'am,
Yes,
your
yes,
voice is
yes.
breaking, ma'am.
Okay, okay.
It's not
I
clear,
will
ma'am.
just. So now is it all right?
Now it's
This
okay, ma'am.
then you can discuss. It's okay. Now
Okay,
you
okay,
can
ma'am.
also discuss about the classical theories, different theories that I will be describing late, and then you will be discussing about the clinical relevance of the growth and development and the different theories. Now, growth basically it is an anatomic phenomenon, and it is quantitative increase in size or number, and it's given by the definition by given by Todd in 1931 is growth is basically increase in size, whereas development it is a physiological or behavioral phenomenon, and Todd defined it as progress towards maturity. Moyer, on the perspective, give a integrated view that growth is change in any morphological parameter, while development is progress towards maturity. So, growth is a quantitative or anatomic phenomenon. It has a predictable pattern and variability, and it has a measurable in units like centimeter, gram, etc. Whereas development features, it is qualitative, that is physiological. It is unidirectional and sequential. Its assessment is by a complexity indices. Now, there are a lot of theories explaining the growth of the craniofacial skeleton. Now, the classical theories are the genetic theory, bone remodeling theory, sutural theory, and the epigenetic theory by James Scott, functional matrix thesis by Melvin Moss, which is most acceptable theory, and cybernetic or servo system theory by Petrovic. Van Limburg's compromise provides an integrated view of genetic, epigenetic, and environmental factors. So first I will be talking about genetic theory. It was popularized by Brody in 1940s. According to this theory, that growth of craniofacial structure is governed by the genes and is pre-programmed. And this theory states that genes such as homeopox, sonic hedgehog, transcription factor, and IHH protein play an important role in the craniofacial development. Then Brass in 1930s, they gave a theory like bone remodeling. According to this theory, bone growth occurs because of bone remodeling, like bone apposition and bone resorption. So growth says that both maxillary mandibular bones get bone deposition at the posterior surface. Seacher that came out with a sutural theory, and according to his theory, sutures are primary growth centers under direct genetic control, and the mechanism is proliferation of connective tissue at the sutures pushes the bone apart. Example, circummaxillary suture system pushes the maxillary downward and forward. But this sutural theory by Seacher is later disproved because experimentally it has found out when two facial bones with sutures are placed in different sites like in an abdominal sac, that the growth stops. So now these sutures are seen as growth sites, like passive growth sites rather than active growth centers. Coming to the cartilaginous theory given by James Scott, which believe in the concept that cartilage acts as the very pacemaker of craniofacial. The key site are the nasal septal cartilage for the maxilla and the condylar cartilage for the mandible. But they are the primary growth center for mandible. Condylar cartilage is for mandible and nasal septal cartilage for maxilla. So it has been found in study that that if the cartilage is separated and transplanted somewhere else, like an abdominal sac, it continues to grow. Whereas sutures, they stop growing when they are transplanted to a different site. But the sutures, so this theory is partly accepted. But the most accepted theory is the functional matrix hypothesis by Moss. Now, this theory tells that form follows function. Skeletal tissue grows only in response to functional needs of soft tissue. Like, suppose we are doing mouth breathing. Because of functional absence of the oral cavity, there is, in case of mouth breathing, there is maxillary excess, whereas mandible is retruded. Now, this functional matrix hypothesis, they have a, functional cranial component, and this functional component are basically present bones, then the tissues, soft tissues, the organs, different empty spaces, and skeletal structures which perform a specific functions chewing, like respiration. Then they are called the functional cranial component. See, this functional cranial component has got two parts. That is functional matrix, which is soft tissue component, and the skeletal unit, which is hard tissue. So it has been found out that if the brain grows, that is the soft tissue or the functional matrix performed, then only the skeletal grows. Means the cranial bone grows. This functional matrix again has got two parts, that is the periosteal matrix and the capsular matrix. This periosteal matrix are basically the matrix and the brain.
Shabnam, the voice is cracking. Yeah. Is it the network?
I think so. The network, yeah, just voice is cracking. So have you told them? जो Wi-Fi बंद होती है, have you told others to close the Wi-Fi to stay here? Madam, is it all right now? Hello, madam.
Yes, it is. Yes, yes.
Sometimes it's break.
Actually, Dr. Shabnam, there is a
Yes.
break in between. I mean, few words are missing actually in your
Yes.
voice.
So
Exactly.
I'll
So,
talk
is it
this way.
possible that you change the internet? Like maybe internet issue is there.
Madam, sir, internet, so I can't change. It's a Wi-Fi. I have attached LAN connection. I have
So
attached.
maybe that internet issue is there, and it is not a good network today. Maybe because of rain and all that. So if you can try it using hotspot or something else, it will
Hotspot.
be better.
Okay, okay, there. Should I continue, sir? And my student will just attach it to.
Yeah. Continue,
Yeah,
madam.
yeah, you can continue. Otherwise, it's
Just
in
one
between
minute.
only. Like few words are missing. So
Okay, I'll
otherwise, it's
just try to
okay.
take
Reasonable, it is
notes.
okay. It's not really bad, but few words are missing.
Yeah.
Okay, okay, sir. Just trying.
Shabna, you need to reshare your screen because
Shabnam, you there? I think your audio's cut.
yeah, she's muted.
I am there, ma'am. I'm just changing the hotspot and then
Yeah,
resharing.
Okay.
yeah. Even you can check the net speed by using some net speed software or something online. So if it is around 50, then it is reasonably good for Zoom meeting.
Okay, sir. Ma'am, I'm just getting out of the session and I'm joining again with a new network. It's not getting
No
connected.
problem. Perfectly
No
fine.
problem. Yeah.
So, Neela?
Shabnam? Looks like she is not rejoined.
I think Dr. Shabnam is not able to join yet.
Sir, we are calling her, sir.
Uh,
Sir, sir, she said she'll join in 2 minutes.
okay, great.
Am I audible, ma'am?
Yes, you are audible,
Okay.
Shabnam. Yeah, you can share your screen.
Okay, ma'am. Shares. Ma'am, is the voice all right now?
Yes, it is.
Okay, ma'am. I'm just sharing it.
Make it full screen. It's seen.
I've just come to this. So, is it visible, ma'am?
Yes, it is.
Huh. Okay. So, the next theory that I will be talking
Full
about
screen. Huh?
is servo system theory, where there is a cybernetic
Make it full screen.
approach. Okay, okay, ma'am. Just full screen. Ma'am, is it full screen?
It is.
It's all right, no?
Yeah.
So the next theory that I will growth theory I will be discussing is cybernetic approach. Growth is a feedback loop involving the central nervous system, hormones, and soft tissues. And the mechanism, the occlusion act as a comparator. If teeth don't fit, muscles move the mandible, stimulating the condyle. And the significance is it explains how functional appliances modify the growth. Van Limburg's multifactorial view. It's based on the genetic factor, epigenetic factor, and environmental factor. Genetic factor, it has intrinsic genetic factor like the bones and local genetic factors like neighboring tissues. And the general epigenetic factors are the growth hormones, and the local epigenetic factors are like brain growth or and the environmental genetic factors, the environmental, local environmental factors, muscles, then habits, and versus the general environmental factor, oxygen and nutrition, all these controls the growth of the craniofacial structure. So in this theory, they concluded that growth is a result of the interaction between these five factors like the genetic factors, general and local epigenetic factor, local and general environmental factor. Now, the clinical significance of growth and development and the theories explaining the growth and development are it will help in determining the treatment timing, it will help identifying the peak height velocity using the cerebral vertebral maturity index or Henry's radiograph. Growth modification like function using functional appliances we can use during active growth for which we can determine using different growth theories and predicting the post-treatment stability we can predict by through this growth theories and timing of the orthodontic surgery growth completion. These all we can understand from the growth theory, which are again the discusses how growth occurs and how we can assess growth by CVMI or Henry's radiograph. The second question that asked commonly are the growth assessment parameters. Now, the growth assessment parameters you can tell the skeletal age, dental age, and the somatic age. Now, skeletal age determinations are assessment of maturity of the skeletal structure, and dental age assessment is based on the development of teeth, whereas somatic or physical age assessment overall physical maturity. Now, major growth assessment parameters are cervical vertebral maturation index. Basically, this maturation of cervical vertebra C2, C3, and C4 are seen on the lateral cephalogram. So you don't have to take an extra radiograph in these cases. And the cervical vertebral maturation index, they determine 6 stages, CS1 to CS6. And it is based on the shape of the vertebral bodies and their lower border structure. Now, this is a very reliable indicator for skeletal maturation and helps in timing of the growth modification and orthodontic treatment. The second major growth assessment parameter is the hand grit radiograph, there are many methods, but Grulich and Pyle method is used commonly to determine the growth assessment. And what it assesses basic skeletal maturity based on development of bones in hand and wrist, and the different methods. Basically, this in Grulich and Pyle method, they have an atlas of hand wrist X-ray starting from 0 age to 18 years age. And the hand wrist X-ray that we have, we can match it from the atlas, and we found out the stages. And stages are from A to H is immature and H is the mature one. And this hand wrist radiograph, it is considered a gold standard for the skeletal age determination, and it is useful in treatment planning and growth prediction. Now, other growth assessment parameters are dental developmental parameters like NOLA stages. It basically assess the maturity based on calcification and eruption stages of permanent tooth. There are 11 stages starting from 0 to 10, and this NOLA stage we know very well, and starting from initial to complete root formation. And it is useful when hand wrist radiograph is not visible. It helps in age estimation and treatment timing. Dental eruption can also help in determination of growth assessment. When basically the maturity based on eruption status of permanent tooth. The clinician visually assess the eruption, and eruption charts and sequence by dimension method can also determine the growth status by using the dental eruption. It is a simple and non-invasive cost-effective method. And you can also write about the timing of the major growth spurt. I will be talking in detail about the timing of the major growth spurts. Then you will be now also the various supportive radiographic parameters that can also be used as an growth assessment parameters like Sela Nassian length. If there is increase in the Sela Nassian length, which correlates with anterior cranial base growth. Whereas when anterior cranial base length increases, if there is forward jaw population changes. And in the you can also write what are the pubertal growth indicators, like in somatic or pubertal growth indicators, we can use the height, that is peak height velocity, PHV indicates a pubertal growth spurt. Then menarche in child can also be used as a parameter. Voice changes in boy indicates pubertal growth. Secondary sex characters like development of facial hairs, breast development can also be used as an growth assessment parameters. Now, it's very important to integrate this growth assessment parameters for the clinical practice. That also you have to write. So, smart growth indicators basically they track the longitudinal change in the standing height, weight, and head circumference in classic and highly objective. Now, this Cameron's curve, this is highlights that different structures like genital structure, neural and limbal structure, different structure shows different rate of growth. And this Cameron curve, where we can see that lymphoid structure have 200% increase in the growth during the puberty, whereas it decreases after puberty. Whereas in the genital curve, can see in puberty there is sudden increase in the growth. Whereas in case of neural, 96% of the growth of the neural tissue is completed by 5 to 6 years. So these are also growth parameters that you can use. Then hand rate skeletal age can already I have told can be used as an maturation indicators. There are many methods. SMI methods can also be used, which evaluates 11 skeletal maturation indicators across 6 prominent anatomical sites. Now, cervical vertebral maturation index, I have already discussed first that we can use that for determining the growth parameters. I can use as in growth parameters. Now here we determine the shape of the C2, C3 and C4 cervical vertebra and their lower border structure. Now inferior border most basically when it is in stages, CS1 to CS CS1 to CS2 is prepubertal when the structure of the cervical vertebra is trapezoid and their lower border is almost flat. Whereas during CS3 and CS4, which is the pubertal stage, when the structure of the cervical vertebra, it's changed from wedge to rectangle, and their structures are gradually like C and C3, their inferior border starts becoming concave, whereas in CS5 and CS6, their structure changes almost to square, and their inferior border concavity appears both in C2, C3, and C4. And by seeing this in the lateral cephalogram, we determine the growth status of a person. Now, dental maturation stages can also help in determining the growth status. These are also growth parameters. So, basically, Demichian's method is a gold standard for dental age assessment. It standardizes 8 developmental stages starting from A to A. Localized average growth actually parameters it like so
Ma'am,
yes.
Shabnam ma'am, your voice is still
Yes.
breaking.
Still breaking.
Audio is not clear.
Okay, I will try. One. Hello. Is it all right now?
Now it's okay, ma'am.
Okay. So basically, the growth parameter, when we use somatic growth parameter, the advantage it is non-invasive and it tracks a full somatic peak. Whereas skeletal like hand wrist X-ray or cervical vertebral maturity index, these are highly comprehensive and in case of, but they require radiation, and they whereas hand X-ray requires additional X-ray, whereas in skeletal CVM we have an OPG, we can use that to determine the CVM, and the dental age we can determine through the OPG and for early determination of the growth, but it's poor correlation with the skeletal growth. There are many biochemical growth markers which can be used to determine growth. See the insulin-like growth factor, and it increases during pubertal growth, and its acceleration, it increase indicates that puberty had started. Then salivary alkaline phosphatase enzyme activity, which also significantly rises in saliva during bone deposition, indicating periods of rapid bone modeling. Gingival clavicular fluid marker shows biochemical changes reflecting localized alveolar bone remodeling during tooth movement. Now, the clinical significance of growth that we can use our knowledge about this growth about growth and development parameters for growth modification protocols like using Finlock, and like during CS3 and to CS4 we can use twin block treating skeletal class 2, whereas if we want a surgical intervention like automatic surgery, we must use it when during CS6 when the growth already stops. Coming to the third question, that is skeletal age. Skeletal age is the maturity of the skeleton as assessed from the ossification stages of various skeletal structures. And it is the age of the skeleton. You can tell the definition what is skeletal. That is based on the growth and development of the bones. It may differ from the chronological age in years and dental age. Now, what's the importance of the skeletal age when you write that? That it is important for assessment of growth and development, diagnosis of growth disturbance, for treatment planning in orthodontics and pediatric orthodontics, for forensic age estimation, assessment of systemic conditions, evaluation of treatment outcome. Now the stages related to growth, you can the skeletal related skeletal age. So you can tell about prepubertal, which is determined by CS1, CS2, and pubertal growth spurt, that is CS3, CS4. and mid-puberty CS4, whereas CS5 is late puberty and post-puberty is CS6. Now, the common method to say skeletal age is the hand wrist method. That is the golden method, and we can use the Grulich and Pilus atlas. I already mentioned that they have an atlas starting from birth to 18 years. You take a hand wrist X-ray and then compare that with that atlas and found out what is the skeletal age of the child. And we can use the CVM, that is a cervical vertebral method, and through the lateral cephalogram, and we can determine the 6 stages from that. Now, what are the factors which affect the skeletal maturation? That also you can include in the when you write about the skeletal age. That is the genetics, endocrine factors, nutrition, physical activity, and systemic diseases. So I'm not going in detail about already I have told about skeletal age. So in detail for biological ability, you can this skeletal age also have a you can tell about somatic sexual dental age here, and the hand wrist method in detail you can write how only I have told about Grulich pile, but if you know the Fishman system, Jort method, Brave and Brown, and you are writing fast, you can add these methods. I'm going fast as because we have to have to talk about lot of topics. And Fishman's 11 SMIS, which is a systemic assessment of 6 sites: thumb, index, middle, little finger, and radius. This also you can, Fishman's maturity indicators can also be used for determination of the skeletal age. You can write shortly about that. CVM methods, write short about that. What is their advantage, disadvantage, what is CVM method, that you can write. The 6 CVM stage, you can just make a small like about what is CS1, what is CS2, CS2, CS4, CS5, CS6. So I have told a little bit about this, how CS1, there is a lower body span, body trapezoid. CS2, there is slight concavity, whereas in CS5, deep concavity, square bodies. And clinical growth spurt correlation with skeletal maturity, you can plot a diagram here. And this one point can add that one of the most critical events in skeletal age determination is location of the ulnar side of the metacarpopharyngeal joint of the thumb. And the timing is its appearance signifies that the pubertal growth spurt has begun or is about to reach its peak within first year. Now coming to the growth hormone. Here you can also get a 10-number question on growth hormone. Growth hormone are basically somatotropin, is a peptide hormone secreted by the somatotrop cells of the anterior pituitary. It is a single chain polypeptide with 191 amino acids with a molecular weight of 22 K Dalton. It has a similar structure to prolactin and placental lactogen. And basically I will be telling about the you can tell about the regulation of the secretion, mechanism of action. I will be talking in detail later, but how you will be writing the question that I am writing, what is the definition, what is growth hormone, their structure, regulation of secretion, mechanism of action, then their physiological effect on bone, muscle, fat, carbohydrate metabolism, and other, and the clinical aspect. If there is a growth excess, what happens? If there is deficiency, what happens? Then diagnostically, how you evaluate that? We evaluate serum insulin like growth factor 1 level, which reflects integrated growth hormone secretion, and also the therapeutic application you can add in the when you write about growth hormone and 10-number question. This growth hormone somatotropin is a 191 amino acid, and this secreted by the anterior pituitary gland. And this growth hormone release occurs in a pulsatile episodic fashion. Secretory buzz correlate with the circadian cycle. Peaking during deep slow sleep, secretion is strongly stimulated by growth hormone releasing hormone and physical exertion, systemic stress, fasting, and deep hypoglycemia. There is a hypothalamic pituitary axis. Now, hypothalamic growth hormone releasing hormone stimulates growth hormone synthesis and release, whereas somatostatin, which is the growth hormone inhibiting hormone, exert inhibitory control. Coming to the feedback loops, now how systemic growth hormone level stimulate the hypothalamic somatostatin, which is the growth hormone inhibiting hormone, which give a short loop feedback, which causes decrease in the secretion of the growth hormone, while insulin-like growth factor 1, which is produced by the liver, inhibits the secretion of growth hormone through long loop feedback. You can tell about the systemic bone hemostasis that growth hormone effects on protein synthesis, skeletal modeling, and anti-insulin shunts. Now, also you can talk about effect of growth hormone on craniofacial growth sites. Like the maxilla undergoes prominent periosteal bone modeling under direct growth hormone and insulin like growth factor 1 influence. Growth hormone stimulates cellular proliferation at the circummaxillary sutural system, facilitating passive forward and downward skeletal displacement. And the mandibular condyle, like the secondary cartilage of the mandible condyle, contain highly receptive growth hormone receptor and insulin like growth factor 1 receptor. And this growth hormone triggers the division of progenitor cells in the pre-chondroblastic zone, while insulin like growth factor 1 derives their subsequent endometrial deposition. Odontogenic manifestations. Like growth hormone receptors are present in dental papilla, while growth hormone stimulates odontoblastic proliferation, enhancing dentine and cementum deposition. And growth hormone also regulates eruption velocity. It delays dental age. Clinically, growth hormone deficiency results in a severe delay in tooth eruption, prolonged retention of deciduous dentition. Optimal systemic growth hormone or insulin like growth factor 1 level promote the necessary osteoplastic bone adoption and osteoblastic bone deposition required for rapid stable orthodontic tooth movement. Now, while talking about growth hormone, we have to talk a little bit about pituitary pathologies. Like pre-epiphyseal fusion, excess production of growth hormone causes pituitary gigantism, whereas post-epiphyseal fusion, excess production of growth hormone produces acromegaly, leading to extensive periosteal bone reactivation. So, clinical signs and pronounced mandible prognathism, expanded mandibular angle, frontal sinus bossing, generalized pacing due to tongue enlargement. So, in case of pituitary dwarfism, there are certain facial skeletal morphology change in dental development, and intraoral soft tissue changes, TM joint, mandibular changes. So, in case of pituitary dwarfism, there is severe micrognathia of maxilla and mandible, extremely delayed eruption of tooth, atrophic mucosa, small condyle, and increased or obtuse gonial angle. Whereas whenever growth hormone excess like acromegaly, there is skeletal class 3, macromandible, normal tooth structure but prominent interdental diastema, macroglossia, thick lips, generalized gingival hypertrophy, enormous condylar hypoplasia, obtuse gonial angle. Now, what is the clinical relevance of growth hormone? So, successful growth modification protocols like using myofunctional appliance rely heavily on an active endocrinal growth hormone and or insulin like growth factor 1 axis. Children with growth hormone deficiency show limited response to orthopedic appliances unless they are receiving recombinant human growth hormone replacement therapy. Surgical and post-treatment therapy also very much determined on the improper or adequate release of the growth hormone. Acromegalic patients seek orthodontic treatment or orthognathic surgery must be biologically stable beforehand. Coming to the fifth question, that is growth trend virus versus growth spurt. Now, basically, growth is a general continuous pattern of increased size of body or part over a period of time. It occurs at a gradual or relatively steady rate, whereas growth spurt, the period of rapid acceleration in growth that occur at predictable ages. It is short-lived but not increase above the underlying growth trend. So growth trend is a gradual, continuous procedure. You can write about the difference, whereas growth spurt is a sudden temporary one. Growth trend is long duration, growth spurt is short duration. Growth trend, there is lower rate of increase relatively it is steady, whereas growth higher rate of increase, but it is above average. It forms a baseline, it produces deviations. It can be predicted, like growth trend can be predicted by standard growth charts, whereas growth spurts occurs at predictable ages, but timing varies between individuals. So, as you can see in the growth, you can see there is a graph showing a relation between growth trend and growth spurt, where you can show there is peaks or upward jumps above the growth trend line of growth spurt. You can also write how the growth spurts clinical significance in dentistry. I will be talking about that in a separate question where they ask like questions like what is growth spurt and its clinical significance. So I will be talking about that in the later part of the question. But in this way, you can write about difference between growth trend and growth spurt. And so growth trend is, I have already told that it is overall trajectory, direction, vector of beneficial change over time, whereas growth spurt is a sudden physiologic acceleration in growth rate over narrow window. Now, craniofacial growth trends define the long-term predictable pathways, like mandible rotation. Those studies highlighted internal rotational trends that dictate individual growth pattern, and secular trends refers to multi-generational shift. Like nowadays, the children they are having menarche much earlier. Earlier, the menarche is starting in girl maybe at 10 to 11, but now they are starting at 9 to 10 years. So this children attaining physical maturity and terminal height progressively earlier than ancestors. Now, differential tissue strengths like craniofacial structures grow along an intermediate pathway between the early maturing and the late adolescent somatic curve. Coming to the growth spurt, there is chronological growth spurt like infantile growth spurt occurs around age 3, juvenile or pre-puberty growth spurt occurs between 7 to 8 years in females, 8 to 10 males, whereas pubertal growth starts in females 11 to 30 and males 13 to 15 years. Now, growth spurt or growth maturation can be tracked by hand-wrist skeletal age determination, CVM indices, and serum biomarkers. Already I have discussed about all this. Now, you can also discuss about the clinical intervention of the timing of growth trend and growth spurt. Now, suppose it is in skeletal cast 2 and we want a mandibular advancement. In these cases, pubertal spurt occur in CS3 and CS4, and at this stage we can go give a pickup. Whereas in skeletal class 3 where we want maxillary protraction, with pubertal or CS1 or CS2, we can start the treatment. Whereas in skeletal transverse, where we want to go for, where posterior crossbite is there, we want to go for rapid maxillary expansion, we can start that in late juvenile or early adolescence stage. Which is minimally interdigited at that time and offers lower resistance. And late growth strain and stability, late mandibular growth. Even after the pubertal spurt finishes, slow linear growth trends persist, potentially leading to mandibular rotation and late lower incisal crowding. And for orthognathing surgery, intervention must be delayed until the growth is finished. Sixth question, that functional matrix hypothesis, it is a clinical application and constraint. Functional matrix hypothesis, already I have discussed little bit about during when I was discussing about theories of the growth. So there is a gist how you write about little bit about functional matrix hypothesis. It follows function given by Moss in 1962, and by write more about their clinical application, like how it helps in clinical practice. It guides growth modification. It helps in habit management, in airway and breathing, for occlusal rehabilitation, for interceptive orthodontics, for orthognathic surgery, for functional diagnosis and treatment planning. Whereas limitation of functional matrix hypothesis are that it is not the sole determinant, and there is a complex interaction between the function and form. It's multifactorial. It's not always predictable or linear, and it has got clinical limitations. Because the results of functional therapy or habit correction depend on patient compliance and growth stage, severity of the problem, and timing also. And environmental and socioeconomic factors like poor nutrition, systemic disease can also influence growth, which the theory does not fully addresses. Whereas the evidence is sometimes indirect. Much of the support for the hypothesis is based on the observational and experimental data. Direct proof in humans is limited. And the individual variability of the functional matrix hypothesis is there. Different individuals respond differently to similar functional demands or intervention. And this functional matrix hypothesis is not applicable to all conditions. And the last one, the environmental and socio-economic factors, that is poor nutrition, systemic disease, social factors can influence growth, which the theory does not fully address. So you can write in this way. So I'm not going in detail about this functional matrix theory because already I have told a little bit about the functional matrix, but also about detail about functional matrix theory. But there is some revision of this Mosses functional matrix theory 1997. You can add this, that there is a mechanoreception. Moss updated the functional matrix theory in 1997, bridging the macroscopic growth to cellular levels. Osteocytes and mechanical loading like muscle traction, tuned forces, interstitial fluid shear stresses. Then connected cellular network like mechanosensation is transmitted through the connected osteocytic canalicular network via integrins, gap junctions, and stretch activated ion channels. Now there is another factor, that is epigenetic control. Physical forces act as epigenetic signals that regulate gene expression in skeletal cells, converting mechanical stimuli into biochemical responses. And you can also explain the clinical aspect of this functional hypothesis, functional matrix hypothesis, and it has a therapeutic rationale, functional and skeletal redirection. Malfunctional appliances do not apply mechanical forces directly to the teeth. Instead, they work the functional matrix. Then Frankel appliances uses the buccal shields to remove the cheek muscle pressure from the dental arch. This allows the intraoral periosteal matrix to expand the alveolar bone passively. And retruding the mandible using pin block alters the capsular positioning, stimulating cellular proliferation at the condyle to adaptively catch up with the translation. And we can explain this using craniofacial pathological states like microcephaly versus hydrocephaly. In microcephaly, brain expansion fails, leading to small calvaria. Like brain or the soft tissue function are the primary growth sites, which causes the secondary growth of the calvaria. So when the brain expansion phase, there is small calvaria. Whereas in hydrocephaly, expansion causes massive passive calvaria enlargement because the brain increases size. As a result, there is passive calvaria enlargement. Coming to the second question, seventh question, clinical significance of growth spurt in pediatric dentistry. You have to write little about growth spurt. I have told already about the growth spurt, how it is important in pediatric dentistry, the timing of the growth of spurt, of the major spurt you can tell, how you can assess the growth spurt using how Hendrix radiograph, cervical vertebral matchable method, growth charts, dental maturation by Nola evaluation, and then you can write about the clinical significance, how this growth spurt can, that I will be the, but the fallacy is that the chronological age correlates poorly with individual biological timetable. So up to 72% of children exhibit developmental acceleration or deceleration pattern that deviate from the calendar. So clinician must utilize physiological maturation indicators instead of chronological age. So we can use more growth spurt rather than chronological age to diagnose and treatment planning. Like skeletal maturation, we determine by growth spurt, we determine by the Hendrix X-rays, somatic indicators like peak height velocity, dental maturation using Nola's measure. So as we are discussing about the clinical significance, so you can write about the mandibular advancement timing, like skeletal class 2 malocclusions. When we want mandible advance, we want it using twin block. So gold standard is when the CVM stage is 3, 4, or hand wrist SMI 5 and 6. We can use that. When there is class 3 or transverse therapy in class 3 mechanics, true class 3 correlation when we use face mask, unlike class 2, class 3 or orthopedic therapies, it is started in CVM stage 1 and 2. And all of these we can understand by determining growth span using different skeletal age determining parameters. And rapid maxillary expansion mostly we use during the pubertal stage. And implant placement also help. We can from this growth part helps in determining the implant placement, though we don't use implant in children because dental implants behave like anchors because they lack any periodontal ligament placed during active growth spurt. They remain stationary while surrounding structure continue to grow. As a result, the implant become infra-occlusion. So mostly pediatric implants are inserted after the growth stops. So this is the somatic growth velocity graph. You can draw and explain this. And this is maturation and decision timeline. How childhood addition, active pubertal insert, post-birth determine what type of treatment we can be given. Now coming to 8, the factors influencing growth and maturation. There's numerous factors. You can write what is the key concept about growth and maturation. Then you can write about the different factors like the genetic factors, nutritional factors, hormonal factors, environmental factors, health and disease factors, prenatal factors, perinatal factors, physical activity, sleep, how these factors affect the growth and maturation. Now, biological factors they mostly are genetics, which hello, hello, inherited traits such as height, body build, predisposing certain diseases like Down syndrome, sickle cell strongly influence the growth. Hormones like growth hormones regulate physical sexual maturation. Factors like prenatal condition like maternal nutrition, exposure to radiation, infections like rubella can affect fetal growth. Then environmental factors are nutrition, climate, seasonal variations, pollution, toxins can impair development and growth. Now, factors influence socioeconomic status, family income, living conditions, prenatal, parental education, family structure. Found if it is small structure, nutrition is more. Sometimes growth is more in the child. If it is a suppose it's a number of the child, first child, it has been found in the study they have smaller size, but they have with higher IQ. And there is function and social factors, emotional support, secure attachment and positive reinforcement foster confidence and social see peer interaction, socialization helps develop communication, cooperation, cultural practice. Then other are health and medical factors, infectious diseases, accident, disabilities, access to healthcare can affect also growth and development. Next, I will be talking about mental and physical growth of facial structure. This is basically a very huge chapter about embryology, but the common questions that they ask that define growth and development, describe and detail about pre and postnatal development of mandible. So you can write about development of mandible, like mandible prominence, how Meckel cartilage forms the scaffold, how the ossification begins at 8 weeks, lateral to Meckel's cartilage, then a condylar cartilage appears, then the rapid growth via condylar cartilage and formation of processes and tooth work. Fourth, there is mandible, rapidly then ossifies, condylar cartilage rise, posterior superior growth and symphysis joints hubs. So there is a growth again when it's a question about growth and development. You have to give the definition. So prenatally, first the mandible arch is derived from the first pharyngeal arch. Meckel cartilage serves as a template through the though the mandible forms laterally. The migrate to form the primitive facial structure by the foot. Mechanism of formation, intramembranous ossification forms the bulk of the body and ramus up to the mandibular foramen. It starts around the 6th and 7th week of IUL. Endochondral ossification occurs at secondary cartilage, including the condylar, coronoid, and mental cartilage. Condylar cartilage becomes the most significant growth center, fusing the ramus by the 4th month of future life. Now, growth prediction. Postnatally, the mandible appears to grow downward and forward. However, in the actual biological growth occurs upward and backward at condyle and this reactive displaces the entire bone away from the cranial post. So postnatal growth sites are condyle, there is ramus, alveolar processes. So three-dimensional expansion occurs in the mandible. Width increases completes first. Minimal changes occur in the intercanine width. Height continues for the longest duration, primarily driven by alveolar bone growth and activity. And the length of the mandible increases through posterior ramus. Remodeling shows significant acceleration during the pubertal cycle. Remodeling occurs throughout life by structural adaptation. In Lowe's V principle, we have to understand the growth of mandible. That bone is deposited on the inner side of the V and resorbed on the outer side. This allows the mandible to increase in size while moving toward the wider end of the V space. Coming to row location, this process results in simultaneous enlargement and relocation of units, ensuring the chin moves forward while the ramus moves backward. Now, developmental comparison of the prenatal phase and the postnatal phase of the mandible. So, in the prenatal phase, the primary center of the growth is the Meckel's cartilage, whereas in postnatal, the primary center is the condylar cartilage. Ossification start prenatal phase 6 to 7 week of IUL, whereas in the postnatal phase, remodeling and ossification start. Ossification symphysis, two separate hearts during prenatal phase, fuses this symphysis at the first year, and the direction in the prenatal phase lateral to cartilage, whereas the direction of the mandibular growth is downward to forward translation. So 20 years of age, average age when the mandibular growth typically seizure. That's why if you want to go for a orthopedic surgery, you have to go at least 18 to 20 years. You have to wait. The pivotal spurt in girls, it is 12 to 14, and boys 14 to 16, which are critical for functional. Come to the age changes mandible, you can talk about the childhood, late childhood, adolescence, early childhood, middle age, late childhood, old age. You can the different structures, how they changes, like the body, ramus, mandibular angle, condyle, alveolar, and the mental foramen. So you can the visual guide, you can how the mental foramen changes, how the radiograph appearance with the change, you can include here. You can also add the clinical and forensic significance of the age changes of mandible, and the last you can give a summary. So these are the structures of the mandibular development from infant, child, adult, and elderly. At birth, it is consisted of two segments. It is too small, contain the deciduous tooth germ, and the mental foramen, it is near the crypt of the primary molars. And at birth, it is very small, and the mandibular angle make 160 degree. The condyle is located in one line with the upper border of the mandible. Coronoid process is large at higher level than condyle. And the sigmoid notch between the coronoid and condylar process is very shallow. And at the childhood, the body of the mandible increases. And I think I'm going quite late, so I will just go in detail. It's short. The mandibular canal and mental foramen lower border at 6 years. Very important point is condyle and coronoid process increase in length make the sigmoid notch becomes more deeper. Mandibular angle decreases 140 degree. At adult age, the mandible increases as the size due to bone deposition and eruption. Mandibular canal and mental foramen located at the region of the premolar, and the ramus grows till the age of 20 years. Condyle becomes higher level than the coronoid at the adult. In the old age, there is decrease in the height of the mandible. Mandible canal and mental foramen become closer to the upper border, and by the loss of the alveolar bone, the old individual tries to bring the upper and the lower jaw near each other during mastication, which makes the ramus to bend backward and by the action of the masticating muscle. And the mandibular angle here increased to 140 degree. Describe the development of the maxilla and describe the etiopathogenesis of cleft palate. So in short, you describe the development, how the maxillary process arises from the first pharyngeal arch, how the maxillary process grows medially, fuses with the medial nasal process to form the upper lip. Then the parietal shapes arise from maxillary process on the either side of the trine, and the shelves elevates horizontal position, fuses with each other in the midline with the nasal septum, and the fusion completes by 10th. Now, also here you have to talk about etiopathogenesis. So etiopathogenesis of the cleft palate. Cleft palate results from failure of palatal shelf growth, elevation, adhesion, and fusion with each other or with nasal septum. There is multifactorial etiology. Either there is genetic factor, environmental factor, embryonic factor, and other factors. The genetic factor includes many factors. I can later share this slide so you can go through, because now there is no time to talk about all these factors. And this pathogenic sequence of this multifactorial etiology, either there can be a normal palatal shelves, or there is elevation shelves. And normally it's the palatine shelf elevates to horizontal position above the tongue, adhesion, then fusion. If there is failure at any stage, then only the cleft palate occurs. And the type of clefts, cleft lip, cleft palate, or combination of cleft lip, cleft palate. You can also give the views classification of cleft lip, cleft palate here. So maxillary develop, I'm not going in detail anymore. So yeah, you can cleft palate etiology. There are I've said about genetic molecular regulators for development of cleft palate. So these are like MS61, BMP4 loop, which then FGF10, FGFR2B signaling, TGF beta 3 master signal, IRF6 regulatory pathway. These all controls and these can and regulates palatine shelf fusion, and they can have a role in proper formation of palate or formation of cleft palate. So there is causes different environmental teratogens which causes cleft lip, cleft palate, and also certain diseases like Pierre-Robin diseases which can cause cleft lip, cleft palate. Coming to also there can be questions like write about growth and development of maxilla and its clinical implication. So I'm not going in detail. Already we have discussed a little bit about growth and development, but also here I talk about postnatal growth pattern, that maxilla grows in all directions, but predominantly downward and forward. Maxilla is a sutural bone. Growth occurs at all sutures. Tooth eruption, alveolar growth contributes significantly to the maxillary development postnatally. And maxillary forms a midway skeleton, floor, lateral wall of the nasal cavity. Growth continues into the adolescent period. And the period that also you can tell, and the functional outcomes of the normal maxillary growth that you can write. So I'm not going into detail, but the chronology of maxillary growth you can write, like in what happens in the 4th week of intrauterine, 6th week, and at birth maxilla is predominantly wider, and adolescent rapid vertical development. Postnatal growth. Major craniofacial growth theory can be discussed during the postnatal growth, that sutural theory, nasal septum theory, functional metrics theory, that growth we can describe this theory, and using these growth theory we can describe the maxillary growth. Spatial vectors of maxillary growth. The overall spatial disbursement pattern translate the maxillary complex of maxilla downward and forward relative to the stable anterior cranial base. However, actual surface bone remodeling occurs in the opposite. For instance, height is gained by apposition on the outer buccal surfaces and expansion of the mid-palatal suture, while height gains are dominated by the eruptive alveolar drift. Then you can write about the clinical implication in periodontic, like how mid-palatal suture remains active, non-calcified, and then you can use RME, and during class 3 protraction, use sutural vectors to protract the maxilla. During skeletal class 2 restriction, headgear uses heavy extraoral forces backward. They redirect backward the selectivity maxilla. Now, and mandible, you have to write both postnatal growth of both maxilla and mandible. I'm not going in detail, but also you have to write that This maxilla and mandible, they both work together. The mutual adaptation, maintaining facial balance, maintains occlusion and airway patency. It shapes the nasal cavity, hard palate, and dentition, and growth rate is high in childhood and decrease puberty. You can write about the growth changes of both postnatal and growth and mandible, postnatal growth of the mandible at different period. You can write about the clinical significance, how it affects our treatment, how it affects the airway volume, how proper growth ensures function harmony, disturbance in growth, how it leads to malocclusion, midface hypoplasia. Knowledge of growth is essential, how it is essential for diagnosis, treatment planning. These all you can write here. Now coming to developmental and congenital anomaly of maxilla. So write a little bit about normal development of maxilla and come to classification of anomaly. According to origin, it can be developmental anomaly, college congenital anomaly, and according to structure involved, it can be maxillary site anomalies, palatal anomalies, alveolar process anomalies, maxillary sinus anomalies, syndromic or craniofacial anomalies. By pattern, it can be isolated, it can be multiple or syndromic, it can be associated with cleft. Major developmental and congenital anomalies of maxilla are maxillary hypoplasia, cleft lip and palate, submucous cleft palate, high arch palate, Gothic palate, alveolar cleft. There is maxillary sinus hypoplasia or aplasia, bifid uvula, transverse maxillary deficiency, congenital absence of maxilla, which is very rare. The syndromic are cleft lip syndrome in Vanderwood syndrome, Pierre-Roux syndrome, Ticker-Collins syndrome, Apert syndrome, and Clausen syndrome. So you can write about this little bit and write about the etiology, their genetic factors, maternal drug use, infection during pregnancy, smoking, then radiation, unknown factors. You can write a little bit about the clinical significance of development congenital anomaly in maxilla. So I'm not going in detail about these already. A little bit I have so only I will show this maxillary hypoplasia. You can write also about the minor development of maxilla, the Clausen Apert syndrome, syndromic Tracher Cannon syndrome, dysostosis, hemophage, micromia. And but you can see here the prevalence. It's very difficult to write this type graph where I got it through the AI. It's difficult to write in a paper, like, but you can at least write that cleft lip palate is by far the most prevalent congenital anomaly of the maxillofacial complex globally, where 1 in 700 live births. And interdisciplinary management, you can right that in 0 to 1 year we do pre-surgical orthopedics feeding up to 1 year we do primary palatoplasty to restore speech, 8 to 12 years secondary alveolar bone grafting using autologous iliac case graft, and 16 year onwards we do definitive orthodontic surgery, that's Sleaford advancement. Now development of the palate, so you can write about the development of the primary palate and then development of the secondary palate. You can also write about the condition of the primary palate and the secondary palate, write about the clinical significance. So the palate develops from two components, the primary palate from the intermaxillary segment and the secondary palate from the palatine slabs of the maxillary prominence. I'm not going in detail about this because my time is running already. So also there are questions on development of tongue. Yesterday you had anatomy lectures where you have you have learned about and you are studying about this long development of tongue. So in 4th week, the formation of the lingual swelling, there is growth and fusion, beak shape, there is 8th week, there is final structure and innervation. So tongue musculature basically originates from occipital martums in the 4th week. It migrates anteriorly into the the tongue divides into oral part and the pharyngeal part. Anterior part develops mainly from the first and posterior 1/3 develops from the second, third, and the fourth arches. The body of the tongue forms from tuberculum impar and paired lateral lingual swelling, and the base of the tongue arises from the medial swelling called the copula. A depression called the foramen cecum marks the origin of the thyroid gland. During the 6th and 7th weeks, lateral lingual swelling enlarge and fuse, forming the tongue body. By 8.5 and 9 week, tongue is well developed, and the palatal shelf elevation separates oral and nasal cavities. So it's a 10-mark question, basically chronological, anatomical origin. You write, and then muscle and innervation mapping also you can write. So much of test parts also you can write how in 8th week, 9th and 11th week, 11th, 13th week, 13th to 15th week, the chronology of first morphological signs of specialized lingual papilla that found from circumvallate edge on the dorsal epithelium, then direct neuroinductive into sensory gustatory nerve terminal endings, epithelial cells differentiate into receptors, then filiform papillae develop broadly on the anterior dorsum. You can also write about the tongue innervation matrix, how anterior two-third, posterior one-third, and the posterior motor roots, their embryological origin, sensory like anterior two-third, general sensory innervation by lingual nerve, posterior one-third, glossopharyngeal, posterior most root by internal laryngeal. Applied pediatric anomalies, you can write a bit about ankyloglossia, the type of ankyloglossia, type 1, 2, 3, 4, you can write. Clinical focus, you can write ankyloglossia, how what happens in neonates when they ankyloglossia, difficulty in feeding latching. There is speech development, and there is how you do surgical intervention like frenotomy, clipping during simple clipping, splenectomy, and in older children. You can use laser scalpel. These are all other structural anomalies of trunk like macroglossia, bifid tongue, lingual thyroid. You can add. Now coming to development of dentition and occlusion. The frequently asked questions are various stages of development. So various stages of development. So it's a very big chapter. It's very difficult to tell in short, but what you can write that from embryo to eruption, you have to write the complete overview. So basically there is initiation in the laminar stage, then coming to the bud stage, cup stage, then apposition, and then the eruption stage. You can write the developmental timeline, like when the primary deciduous toothed timeline and the permanent tooth timeline. You can write about the cell origins. You write about the tooth jumps at the primary tooth jump, permanent tooth jump, where its position, sequence of mineralization. You can write. It's very important. Now, I think I will go a little faster. So enamel organ, it's basically embryonic origin, oral ectoderm and epithelial invagination, that is the ameloblast. It's solely responsible for producing the enamel, and ectomesenchyme, which is embryonic origin, is cranial neural plexus, fixed in two crucial subcomponents: dental papilla, dental papilla, follicle. Dental papilla forms a dentine and pulp. Dental follicle forms a cemental, pedial, and alveolar bone. And at 6 weeks to 7 weeks of the oral ectoderm proliferates and invaginates into the underlying ectomesenchyme, forming the horseshoe-shaped dental lamina. In the birth stage, which is the proliferation stage, at 8 weeks of in utero, lamina develops 10 rounded swelling or buds. In each jaw, it consists of peripheral pupil cells and central polyhedral cells. It's in utero, unequal growth results in an atrophic enamel organ over the points, dental papilla, and the key cellular layers are outer enamel epithelium, which are enamel epithelium, columnar cells, stellate reticulum, star-shaped fluid-filled cells. In the stage 4, that is early Bell stage, there is a histodifferentiation. Invagination deepens into the Bell stage. Stratum intermedium appears between a, sorry, uh, between inner enamel epithelium and stellate reticulum. Inner enamel epithelium cells differentiate into tall columnar pre-amyloblasts. Cells induce outer dental papilla cells differentiate into odontoblast, and the dental lamina breaks down, isolating the tooth gel. Stage 5 or advanced or late Bell stage, there is dentinogenesis first. Odontoblasts retreat toward the dental pulp, secreting an organic matrix called predentine. Mineralization begins rapidly, leaving behind odontoblastic processes based in microdental, and amylogenesis follows. The first layer of dentine triggers pre-amyloblast to transform into fully functional amyloblast. Amyloblasts secrete enamel matrix by processes followed by immediate mineralization. Stage 4 is a root formation or crown complete to root initiation. When enamel and dentin reach the future cement to enamel junction, the inner enamel epithelium and outer enamel epithelium fuse to form the Hartwig's epithelial root sheath or HERS, and HERS core epithelium mapping out root. As HERS disintegrates, dental follicle cells touch root dentin, differentiating into a cementoblast to lay down the segmental. This is a comprehensive chronology, and you can write over the clinical and developmental anomalies during initiation stage causes anodontia or supernumerary tooth, extra teeth, and anomaly during differentiation leads microdontia or macrodontia, big laterals, and anomaly during histodifferentiation causes amelogenesis imperfecta, dentigenesis imperfecta. Deciduous tooth timelines you can write. And coming to the second, that is Nola stages of tooth development. So here this is a Nola stage of tooth development. You can draw and describe each stage starting from 0 to 9. 0 is the absence of crypt, 1 is crypt formation, 2 is initial calcification, 3 is 1/3 crown formation, 4 is 2/3 crown formation, 5 almost complete formation, 6 complete crown formation, 7 is 1/3 root formation, 8 third root formation, 9 is complete root formation. And while you are describing about this stages, you can mention about their radiographic appearance, you can mention about their radiographic finding like no calcifications found in the 0 stage, and in 9 there is root formation. So you can also for each stages, you can write about their clinical significance. You can write about the application of Nola stages, that they are used for age estimation, growth and maturation assessment, orthodontic diagnosis and treatment planning, forensic odontology, for research and epidemiological studies. So I am not going in detail about this Nola stage, but in the panoramic radiograph, when you determine the stages, evaluate that is our skeletal age. So is conducted 7 permanent teeth in the quadrant, starting from central incisor to second molar. Examine and match individual radiographic views closely with standard reference diagram. Summing these individual scores yields the dental maturity index. So already I have told the initial phase 0 to 3, 4 to 6 is the crown completion, 7 to 10 is the apex, and evaluating intermittent Nola's classic schema consists of 11 sequential drawing representing standard developmental curves. If tooth sits exactly between two stages, that is then the value will be 4 or 5.5 are assigned. Health trace delayed developmental patterns in craniofacial microsomia and skeletal anomalies. So this already we have maturity index formula, Nola staging, it already have discussed. So next one, discuss mechanism of tooth eruption and add a note on its applied discuss, or there can be question like discuss the mechanism of tooth eruption on the basis of different theories purport and its applied aspect. Now, mechanism of tooth eruption and applied aspect. So first you have to tell about what is eruption. Tooth eruption is a process by which tooth move from its developmental position within the jawbone to its position. First you have to write the definition. Next you have to talk about the different theories. There's theories like tooth formation theories, then bone remodeling theory, then hydrostatic pressure theory, dental follicle theory, functional matrix theory, and most accepted one is the periodontal ligament theory. Now, sequence of tooth eruption, you have to write about the pre-eruptive stage. There is initiation, eruptive movement, and penetration through oral mucosa, functional eruption, then post-eruptive stabilization. So, eruption is basically, again, you have to write that it's an active eruption and passive eruption. Active eruption is again divided into pre-eruptive, eruptive, and post-eruptive stage. Pre-eruptive stage basically occurs within the jawbone, where initiation of the tooth up to the crown formation occurs, and as soon as the crown formation terminates, then it comes to eruptive stage, where it goes from that stage to it comes to occlusion and come in contact with the occlusion. And after in the post-eruptive phase, sorry, so and in the post-eruptive stage, it come in contact with the occlusion and remains there. In the passive, what happens basically, the clinical crown increases in the length because there is this. There is clinical crown is increases because of gingival decision, but it is basically there is a passive eruption, but there is no tooth movement. The mechanism of tooth eruption basically a lot of theories are there, like root formation theory. According to root formation theory, eruption occurs because of increase in the length of the root, but this theory is not accepted nowadays because even rootless tooth can also erupt. And the bone remodeling theory, where it causes that when the tooth moves upward, there is resorption bone over the tooth, erupting tooth, and there is deposition at the base of the tooth, and this is partially accepted for the mechanism of tooth eruption. And there is hydrostatic pressure, that is hydrostatic pressure of the blood vessels at the base of the tooth causes force which causes eruption. But most accepted theory is the periodontal ligament traction theory. According to the theory, there is fibroblast within the periodontal ligament which have subcontractile elements and which contracts, and this contractile element then transmits forces to the collagen fibers present in the periodontal ligament, and these forces translates the forces to the axially or occlusally directed eruptive forces. So there is sequence of events also you can write, that is a pre-eruptive phase. I have already told, movement of tooth from the oral cavity into the movement of the tooth towards the oral cavity post erupted, that is a functional eruption. It continues throughout the age. And so I'm not going about the theories again. So you can write about the applied aspect, about delayed and ectopic eruption. You can write about the ankylosis impaction while talking about eruption. So if there is what are the treatment options, if there is ankylosis or if there is dental impaction, that you can also write. So the last one, I think there is discuss the development of occlusion, its clinical application, and also discuss, there will be another question like discuss the development of occlusion in 3 to 13 years of age. Now development of occlusion, it's initially from birth to 6 months, it is the gum stage, and 6 to 6 years, that is the primary dentition stage, and 6 years to 12 years, that is the mixed dentition stage, and more than 2 years, 12 years, that is the permanent dentition stage. So while discussing that, you can discuss about the flush terminal plane, mesial step, distal step, discuss about the overjet, overbite, leeway space, eruption space, permanent tooth, discuss about the how class 1 molar relation, class 1 canine relationship increase over ideal overjet, overbite. Also write about the clinical significance. Like this development of occlusion has been early prediction of malocclusion, identification of space discrepancy and crowding, guidance for preventive interceptive orthodontic, it maintenance for the arch and leeway space, assessment of eruption, prevention of and premolar dysfunction. So another question, that is development of occlusion from 3 to 13 years. Here you can write like how development of occlusion in 3 to 13 years. 3 to 6, that is the early primary dentition, where there is eruption of all primary teeth, establishment of primary molar relationship, overjet 2 to 4, overbite 1 to 2 millimeter. There is primate space present. In 6 to 9 years, that is the mixed dentition phase or early mixed dentition phase, eruption of first permanent molar, eruption of permanent incisor liability period, leeway space available in the primary molars. 9 to 11 years, mixed dentition or late mixed dentition phase 2, eruption of premolars and canine, first permanent molar, and canine transition space analysis is important at this stage. 11 and 13 years, that is the late mixed dentition, where there is eruption of second premolar, eruption of second molar by 12 to 13 years, establishment of permanent dentition. So key events are eruption of permanent molars, leeway space
Shabnam?
utilization, mesial shift, canine transition, completion of permanent dentition.
Dr. Shabnam,
Now we can discuss
how
about
much more
change in
time do you
occlusion
need,
from
ma'am?
3 to 13 years. Like
Dr.
3 to
Shabnam,
6 years,
how
molar
many?
relationship is flush terminal plane. 6 to 9 years, it is molar relation is flush or mesial step. 9 to 11, it's from flush terminal transition to the class 1. 11 to 13, it's a stable
Dr. Shabnam?
class 1 molar relationship. And overjet
Dr.
in 3 to
Shabnam, can
6
you
years,
hear me?
overjet is 2 to 4 years, 2 to 4 millimeter. 6 to 9 years, 3 to 4 millimeter. Again 2 to 3 years, 9 to 13 years decrease to 2 to 3 millimeter. Overbite again changes. Also you write about the sequence of eruption of the teeth from 3 to 13 years. Write about the everything you write, the clinical significance. Clinical significance, it helps in early detection of malocclusion and interceptive treatment. Leeway space maintenance prevents crowding of permanent teeth. Timely assessment of eruption sequence and space availability guides orthodontic treatment planning. Timing intervention and prevention of future problems. Crowding, crossbite, so these clinical significance ensures establishment of functional, stable, and aesthetic occlusion. So I'm not going in detail about this because already I'm speaking 1 hour. But you have to talk about this early ugly ducting stage broadband phenomenon, then leeway space, uh, normal occlusion, and this is the clinical significance and the so you can complete your
Dr. Shabnam,
questions
how
about
many more?
development of occlusion in 3
Dr.
to 13
Shabnam, can
years
you
and
hear
its
me?
clinical significance. And there are a list of books for reference like Orban's Oral Histology and Embryology, Tenket's Oral Histology Embryology, Essentials of Oral Histology Embryology, and you can also read these few books like craniofacial development, craniofacial growth, the fundamentals of craniofacial growth, craniofacial development of growth by Mitch Perman. You can go to Graeber's textbook orthodontics. You can also read this Gauri Shankar's orthodontics principle and practice. And with that, I come to end of today's presentation. If you have any question, if I'm not able to answer it in this session, you can also email me. And thank you very much.
Hello, Dr. Shabnam, can you hear me?
With that, I come to the end of the session. Thank you everyone for your patience hearing, and thank you very much.
Shabnam, can you hear me?
I can't hear anything.
Hello, Dr. Shabnam.
Dr. Shabnam, Dr. Anjana is trying to contact you. Can you hear her? Dr. Shabnam? Maybe ma'am speaker is not. Dr. Shabnam, can you hear?
Hello.
No, I think
I can't. Am I audible?
You are audible, but you're not
Am
hearing
I
us.
audible? Ma'am, I can't.
Dr. Anjana, can you
Yes,
just
sir.
call her once and tell her? Maybe her speakers are not
Am I
on or
audible, ma'am?
speaker volume
I'll do
is
that.
less.
I'll do that.
Yeah. And maybe you can
I
request her
think.
to share her PPT in the form
Yes.
of a PDF for the
Yes,
benefit
Am
of
I
all.
audible, ma'am?
That would be better.
yes, I will do that.
Yeah.
I think everyone is asking about the PPTs, so I think I can share that PPT to Anjana ma'am or ISPPT.
Yes, Dr. Shabnam.
Hello, ma'am.
Dr. Shabnam, we are trying to contact you. You're not able to hear us.
Achha, ma'am, can you hear me? I'm not able to hear you, but I can. Now I can hear you in the phone. Yes. Uh,
Dr. Shabnam, I think your speaker volume is less. That's why you're not able to hear us.
Ma'am, if there any question, I can just send it or mail it. Those who have the questions, I can just give them the answer. I can type it. I can't hear anything.
Okay, thank you.
It's a problem, I think. I'm not able to hear anything.
Okay, thank you.
Thank you, ma'am. Thank you for that informative session. Kindly accept this. Kindly accept this certificate as a mark of our heartfelt appreciation for your excellent talk and support. Thank you, ma'am.
Yes, thank you, ma'am. Now I can hear you. Okay. Thank you, ma'am.
Thank you.
Thank you, ma'am. And thank you, Virinda, sir. And thank you, everyone here. Thank you very much.
Welcome, Dr. Santosh Pillai.
Now, we are moving on to our next speaker, Dr. Santosh Pilla. Professor and Head of the Department of Pharmacology, and Vice Principal at Pushpagiri Institute of Medical Science and Research Center, Tiruvalla. He has about 23 years of experience in teaching MBBS, BDS, MDS, nursing, and allied courses students. He serves in several important academic and administrative roles, and he has contributed actively to research, pharmacovigilance, and medical education. We warmly welcome you, sir.
Welcome, sir. Sir, you're not audible. Your mic. Welcome, sir. Still, you're not audible, sir. Probably you need to increase the volume, sir. You are not audible. We are not able to hear you, sir. Your microphone is off, sorry. No. We are not able to hear you.
Maybe you need to re-log in, sir. Santosh, sir, just log out and re-log in. Maybe
Sir,
that will
just log
solve
out
your
and
issue.
yes. Sir, we can't hear you. Not able to hear you, sir. Technical support and എടുക്കാൻ പറ്റും.
Hello, ma'am. Are you able to hear me?
Yes, sir, we are able to hear you now.
Yes,
Yeah.
absolutely.
Thank you. That's what I'm wondering. Sorry, ma'am, for that technical glitch.
No problem.
Yeah. Okay, thank you. Thank you for that nice words, Dr. Kavita. Thank you, Dr. Anjana, for this opportunity. Shall I share the screen now?
Yes, sir.
Yeah.
Your screen is not seen, sir. Hello, sir. Hello, sir. Hello, sir. You're not audible, sir. Sir, you're not audible.
Okay, right. Am I audible now?
Yes, you're audible. We can see your video. We can see your screen. You just need to make it full screen.
Yes, you are audible now, but your screen share can be started now. And make it
Okay,
full
okay.
screen, sir.
Uh, okay, I hope you're able to see my screen.
No, sir, not yet.
Not yet.
No, Dr. Anjana, I could see his screen. His screen was there. The only thing is it was not full screen.
Oh, okay.
Yeah.
Yeah.
That's okay.
Yes.
Yeah, you can go ahead with this like this, sir.
Oh,
That
okay, sir.
okay.
Okay. So I'll be discussing about a few
Full
questions.
screen, sir.
Yeah.
Can you make it into full screen?
Yeah. Yeah. So is it okay now, ma'am?
Yes, sir.
Yeah. So I'll be talking about discussing about a few questions that in pharmacology. So without wasting time, I'll move forward. So as we all know, pharmacology, it's a science of drugs, and I think most of you will be aware of the pharmacology classes in your undergraduate studies. So pharmacology, derived from the Greek words pharmakon and logos, broadly deals with the interaction of exogenously administered chemical molecules with living systems and encompasses all aspects of knowledge about drugs. So basically in pharmacology, we divide this into two sections. One is kinetics and dynamics. I hope that's just a revision of your undergraduate studies. Kinetics is just absorption, distribution, metabolism, excretion, and dynamics where we deal with the mechanism of actions, the therapeutic actions of the drugs, adverse drug reactions, and so on. So these are the basic parameters of pharmacology. So as Dr. Anjana had shared a few questions that came up in different universities. So I've made a list of few questions that was asked frequently in most of the universities. So I've just made a list of them. The highlighted ones were asked very frequently, like anaphylactic shock was asked in Rajiv Gandhi University, Kerala University of Health Sciences, MGR University, JSS. Then randomized controlled trials were asked very frequently. NSAIDs and their use in pediatric dentistry was asked very frequently. Adverse reactions of NSAIDs, antibiotics in pediatric dentistry, dosage calculation in children. These were the questions that were asked very frequently, and the others that has been mentioned there were asked in a few university questions. So we'll just go through one by one. I'll discuss the questions that were asked very frequently in a bit detail. Right. So first is anaphylactic shock. So as we all know, it's life-threatening severe type 1 hypersensitivity reaction caused by allergens, maybe due to the administration of drugs, insect bites, stings, and certain foods. So it can be deadlier. So when you get a question on anaphylactic shock, you're supposed to write this particular definition. And then in short about the causes, like what are the mediators that we have just discussed and how it causes these allergic reactions, like the release of histamine, leukotrienes, prostaglandins from mast cells that is responsible for these reactions. And of course, the causes like drugs like mainly penicillins. We all know that penicillins are more prone to produce these reactions. Penicillins, non-steroidal anti-inflammatory drugs, insect stings, food, latex, contrast media, and so on. And something about the basic pathophysiology, like these allergens, they cause the degranulation of mast cells, release of IgE, causing the mediator release, leading to hypotension. So whenever a patient comes with anaphylactic shock, the clinical features in short may be discussed like bronchospasm, laryngospasm, hypotension, urticaria, cyanosis, and maybe the patient in a semi-comatose condition. So these are the features that may be written in short. And you need to write the treatment. So the basic drug of choice is adrenaline, the life-saving drug that we need to keep aside alongside when we go for any type of procedures or injections. So you have adrenaline, 0.3 to 0.5 milligrams given deep intramuscularly in a solution of 1:1000 solution immediately. So it's considered to be a drug of choice. And you can write that adrenaline, when it is administered, it can cause bronchodilation, laryngospasm will be relieved, it's a vasoconstrictor, and thereby increases the blood pressure also. So that is the rationale of using adrenaline. Then other supportive measures like corticosteroids, oxygen, IV fluids, IV hydrocortisone is injected, monitoring the patient. And of course, all these patients, they need to carry a tag that they are having a particular site of allergy, and they need to carry adrenaline auto injector. Most of the people who are allergic, they carry this auto injector. So these are the points that can be included in this particular answer on anaphylaxis. Okay. Next one, very commonly asked, is a randomized control trial. Now, this may be covered in community medicine classes also, but part of this is also in pharmacology. So I just tried to delve into that also. So basically, we know about clinical trials. Before a drug is marketed, it undergoes through a process called as clinical trials, divided into different phases: phase 1, phase 2, phase 3, and phase 4. Phase 1 and phase 2, it is mainly involving the volunteers. The healthy human volunteers are enrolled. And then phase 3 is a phase where a trial is being done with a test drug and a control drug, or the new drug is compared with the standard drug. Okay, so this randomized control trial, it comes under this phase 3, where we compare the new drug with the standard drug. So it is a prospective study. That means a study that goes alongside. It's not a retrospective, it's a prospective study that measures the effectiveness of the newer intervention compared to the standard treatment. And actually, it is randomization is done in this particular case mainly to avoid bias and provides a rigorous tool to examine the cause-effect relationship between an intervention and outcome. Then there are different components of a randomized control trial. The different components are, first is the core methodology of the trial that includes the research trial, the randomization, and blinding. I'll tell about blinding also. Then there comes the study design, where we talk about the informed consent of the patient and the institutional ethical clearance also. And then there is the execution of these trials, like the outcomes, then the sampling techniques, statistical analysis, and all. Then there are types of randomization that includes simple randomization, where maybe just the flip of a coin can be taken as a simple randomization. So heads will go to this group, tails will go to that group. Then there is block randomization, where we divide them into different blocks. Stratified is there, where we divide these patients into different subgroups. Okay. Then there is to avoid or minimizing the bias, we do blinding, single blinding study, where the participants, they don't know which group they belong or which drugs are being administered. Then there is a double blinding technique, where the participants as well as the investigators, they are unaware of which treatment is being given. So it is being administered in covers and then given to the patients and the investigators. So that is considered to be the gold standard, the double-blinded study. Ethical consideration, informed consent to be taken, institutional ethical clearance, and all these trials, it is done under guidelines called as the ICH GCP, Good Clinical Practice Guidelines. So these are the things that should come under the randomized control trial. This has to be elaborated under these sections. Coming to NSAIDs in pediatric dentistry, it is asked in different forms. This NSAIDs, you get a mechanism of action, adverse reactions. All these comes from this particular chapter, 10 marks question. So NSAIDs are the most commonly prescribed analgesic in pediatric practice, inflammatory dental pain. So you need to be aware about the classification, like classified into simple analgesics like paracetamol, ibuprofen, mefenamic acid, naproxen, diclofenac, ketorolac. Then all these are non-selective COX inhibitors. Then you have selective COX-2 inhibitors like celecoxib. But in children, they are restricted only for the management of juvenile inflammatory arthritis. So not commonly prescribed in pediatric population. There are some few drugs that are contraindicated, like aspirin, nimesulide. Aspirin in kids under 2 years of age, especially after viral infection, can cause Ray's syndrome that leads to brain swelling and liver damage. Nimesulide has been banned. Then all the longer-acting piroxicam, indomethacin. Mechanism of action. Mechanism of action of NSAIDs. NSAIDs act by converting the cyclooxygenase enzyme is responsible for converting arachidonic acid into prostaglandins. So this is the point where NSAIDs act. They act by inhibiting the cyclooxygenase enzyme, preventing the formation of prostaglandins that is responsible for the mediator of inflammation, pain, and protects the gastrointestinal mucosa. So by inhibiting this enzyme, NSAIDs produce anti-inflammatory, analgesic, antipyretic. All these actions are produced. And because of inhibiting this enzyme, it degrades the gastrointestinal mucosa, and that's why you get gastritis as an important adverse reaction with NSAIDs. Indication: preoperative, postoperative, acute dental pain, orthodontic pain, swelling plus inflammation. Aspirin not preferred in kids because of Ray's syndrome. Contraindication in bronchial asthma. Bronchial asthma contraindicated because when you inhibit cyclooxygenase enzyme, most of the prostaglandins will be diverted to the other pathway, that is the leukotriene pathway, and that leads to increased production of leukotrienes and asthma. Peptic ulcer, because of that cyclooxygenase inhibition, leads to gastritis and peptic ulcer, GI bleed. According to the American Academy of Pediatric Dentistry guidelines, first line start with ibuprofen or paracetamol, combination for severe pain. And usually we tend to avoid opioids in children under 12 years of age, shorter duration. So mostly NSAIDs are preferred, and mainly paracetamol or ibuprofen. So these are the things to be written under this particular section. Adverse drug reactions of NSAIDs. So if you get a long question on NSAIDs, you can add ADRs that we have mostly discussed. GIT, renal edema, hypertension, acute renal failure, acute kidney injury, all because of this inhibition of PG synthesis. Headache, tinnitus, confusion, antiplatelet action leading to bleeding, hypersensitivity reactions, increase in transaminase levels, hepatitis, delayed labor, premature closures of patent ductus arteriosus. To prevent ADRs, start with shorter duration, take after food. Misoprostol, which is a prostaglandin analog, may be given when there is associated gastritis, or give it along with proton pump inhibitors like omeprazole, or go for COX-2 selective agents. So most common adverse reaction is GIT, more than 30% of cases. Next, a very important question asked in many university exams is antibiotics in pediatrics. So antibiotics in pediatrics, we know that we can't use all the antibiotics that we generally use in adult population in this pediatric use. So the golden rules for pediatric antibiotics: start by dose by weight. We can't give half tablet or 1/4 tablet. So that is not rational. We have to give the dose by weight. Always use milligrams per kg per dose. Organ maturity, because the liver kidneys are immature, and because of that, the half-life may be increased, leading to toxicity of drugs. Bone and teeth are at risk. And always use aware classification. Now, aware classification is a classification usually used for antibiotics given by WHO. Okay, A stands for axis, WA stands for watch, RE stands for reserve. So axis group, watch group, reserve group. Axis group are those groups that are used very frequently. Watch and use. Reserve only used for specific conditions. So always use axis groups like amoxicillin, doxycycline for pediatric population. So these are some of the generally used antibiotics. From penicillins groups, you have the commonly used amoxicillin clavulanic acid, used for dental abscess, pulpitis, facial space infections, severe abscess. Cephalosporins like cephalexin, cefadroxil, cefuroxime, cefixime, mainly used when the patients are allergic to penicillins or syrups. Macrolides, especially azithromycin, when you want once a day dose. Metronidazole, especially dental infections where you have suspecting a lot of anaerobic infections, use metronidazole. Doxycycline, especially whenever there is aggressive periodontitis and gingivitis, acute necrotizing ulcerative gingivitis. So these are some of the drugs that are used in pediatric population. So that can be enumerated. Then drugs contraindicated in children. Tetracycline due to chelating property. Doxycycline can be preferred. Ciprofloxacin, ofloxacin, quinolones, mainly because of cartilage damage, not preferred. Chloramphenicol causing gray baby syndrome, Gray's discoloration, cyanosis of the skin. Sulfonamides causing kernicterus. Aminoglycosides, ototoxicity, nephrotoxicity. So always when you talk about the dosage in children, it should be on milligrams per weight. There are certain formulas like Young's formula, Dilling's formula, and Clark's rule, but these are often outdated. But still, to be accurate, milligrams per kg body weight. Dosage calculation in children. Again, this is often asked, how to calculate the dose in children. Again, children are not miniature adults. So as previously discussed in the previous slide, we can't just break down the tablets and give the kids. So most accurate method is milligrams per kg body weight. And we should be aware about the pharmacokinetic differences like the immaturity of the liver and the kidney, increased sensitivity of the CNS to depressants, compliance factors. Most often try to give those drugs that can be given once a day. If you try to give drugs 2 to 3 times a day, the compliance will be affected. Then these are some of the methods of dose calculation. The most important is the weight-based. Single dose into milligrams per kg. If you want a daily dose, milligrams per kg per day dose. That is the most accurate and used for most of the drugs. So most of the drugs, we need to have the actual dose for what is the adult dose in milligrams per kg, calculate accordingly to the weight of the kid. Then you have another formula based on the surface area, body surface area, where the child dose is equal to adult dose, multiplied by the surface area divided by 1.73 meters square, mainly for anti-cancer and digoxin-like drugs. Then some older formulas like Young's formula, where adult dose into age, into years, divided by age plus 12, that are not used commonly. Just can remember their names, Young's formula, Dilling's formula, and Clark's formula. Can write a few examples also. For example, amoxicillin, the dosage is 20 to 40 milligrams per kg per day, 3 times daily. So for a kid of 18 kgs, it will be 18 into 40, 720 milligrams will be the total dose. So you divide that total dose into 250 milligrams 3 times daily. But remember, never exceed the adult dose. For an adult dose, amoxicillin 500 milligrams 3 times daily means for an adult it is 1500. So this is 720. So never it should exceed the adult dose. Then you can add a table of drugs contraindicated in children, like what we have discussed in the previous slides also. Some practical pearls, especially in kids, give tastier syrups, like amoxicillin tastes better, but if you add cloxacillin, it tastes bitter. Metronidazole tastes bitter and metallic. Frequency, it's already said, azithromycin once daily dose can be preferred, and small doses like 10 ml at a time. So these are the practical points that can be added in the double-blind study that I have discussed along with randomized control trial. So double-blind study is an experimental design in which neither the participants nor the investigators or the researchers know which group is receiving the test drug, what drug is being administered. So mainly intended to obviate the biases in clinical trial, minimize the observer and the patient bias. So here you can write the different types of blinding. Single blind study, where the participant doesn't know what the drug is given. Double blind study, participants and the investigators are unaware. Then there is a triple blind study where even the sponsor or the person who is doing the study is not aware. Okay. So these are so double blind is considered to be the gold standard that eliminates the placebo effect, observer bias, and reliable. I hope you understand what is placebo. Placebo is a pharmacology inert substance that is used to compare a new drug with a test drug or to see the placebo effect of a particular drug. So in the steps involved is first you go for randomization by the methods that we have already discussed. Coding, you put a cover on that so the patient doesn't know. Administer the drug, assess the outcomes, and then you go for code breaking. You break the covers and see what drug was being administered. Limitations, unethical if standard care exists. This means in a diabetic patient, I am giving a placebo. But if a standard therapy is available, it is unethical. Standard care should be given for all patients in a study. So it may be unethical if standard care exists. Expensive and emergency unblinding may be required if something happens to the patient. Examples, new analgesic versus ibuprofen for post-extraction pain using identical capsules. So when you use a placebo, it should be quite identical in color and shape to the newer drug. So that is about double-blind study. That's a part of randomized control trial. Recent antibiotics in children. Again, this is a topic commonly asked. So several antibiotics have been approved in children in the last few years. A few examples have been quoted here. Ceftazidime plus Avibactam 2021 in India. Ceftriaxone plus Tazobactam in 2020. Meropenem plus Vaborbactam in 2023. Then Cefiderocol. That is a novel first-in-class siderophore cephalosporin antibiotic that is used mainly for multi-drug resistant gram-negative infections. Sulbactam plus Durobactam. Lifamulin, the first semi-synthetic plurimutilin antibiotic approved for systemic use in humans. So most newer drugs or antibiotics that were discovered in the last few years are mainly used for multi-drug resistant or extensive drug resistant hospital infections. So these are newer drugs. So in this case, you can just write down the mechanisms of cephalosporins, the mechanism of sulbactam. Sulbactam, it is a beta-lactamase inhibitor. So you can write their mechanisms also along with this. And some guidelines, some changes in pediatric antibiotic guidelines. So according to the guidelines, it said that using amoxicillin alone rather than with clavulanic acid, especially in pediatric population. Antibiotics in dental abscess for 5 days rather than for 7 to 10 days. Azithromycin has been documented. Studies have shown that it can be used for 3 days instead of 5 days. Avoid clindamycin prophylaxis only for high-risk cases. Still, we use the older antibiotics. Most of the dental specialists here knows that drugs like amoxicillin, metronidazole are still considered to be the golden drugs in the management. Azithromycin, ciprofloxacin. Then you can write briefly about the drugs that are contraindicated. Again, in this case, use 90% of access group according to the WHO AWARE classification, and something about the rational use of drugs. Rational use means we use the right drug for the right patient in the right dose for the right duration at the right cost. So that you can write in this answer also to provide rational use of medications. Discuss polypharmacy and its applied aspects in pediatric dentistry. So polypharmacy is the administration of multiple drugs, especially more than 5 drugs at a time. So that can happen mainly because when we go for symptom-based treatment, patient gives you symptoms, one symptoms after another, you tend to add one after the other drugs. Okay. So it could be because of irrational fixed dose combinations, parental pressure. Parents comes to you with a lot of complaints and you give multiple drugs based on the symptoms given to you. diagnostic dilemma, lack of standard treatment guidelines. We are not aware about the guidelines of that particular case. Over-the-counter access. Patient can access any drugs at a time. Consequences about this polypharmacy, it leads to adverse drug reactions. Drug interactions will happen when multiple drugs are given. Drug disease interactions. For example, NSAID is administered in patients with bronchial asthma, can exacerbate the situation because we know that COX is inhibited, leukotriene exaggeration leading to exacerbation of asthma. Dosing errors, non-compliance when multiple drugs are administered for longer frequency, antimicrobial resistance, cost and masking diagnosis. All these are consequences. How to prevent polypharmacy? We should be well aware about the treatment guidelines, especially GINA guidelines in bronchial asthma. Some idea about the guidelines. Okay. Deprescribing. What is deprescribing? Patient comes to you with a list of drugs. Just see which are important, which can be deleted. So that is deprescribing. Generic prescribing, go for generic drugs. Patient education, then drug audit and avoid fixed dose combination. So these are things that can be added in polypharmacy and it's applied in dentistry. Local anesthetics, again, a very important question. So we need to write about the definition of local anesthetics and how it is being classified into injectable anesthetics and surface anesthetics. Okay. If you remember drugs like procaine, lignocaine, chloroprocaine, then high potency drugs like bupivacaine, ropivacaine, soluble drugs like cocaine, ideal properties, all these drugs should be quicker acting, should not be irritable. Then classification with examples, mechanism, the detailed mechanism, the basic mechanism of a local anesthetics, it acts by inhibiting the sodium channels. Advantage of combining with adrenaline. You combine local anesthetics with adrenaline to increase the duration, to produce a bloodless field, okay, to reduce the adverse reaction. So those points can be added. Factors affecting action, lipid solubility can be added. CNS, CVS, allergies, pediatric population, lignocaine is the drug of choice. Role of vasoconstrictors, why you add adrenaline, that's already been discussed. Recent advances like buffered local anesthetic where you add sodium bicarbonate to increase the pH for a faster onset. There is something called as a controlled drug delivery system, computerized drug delivery system, liposomal bupivacaine, but it's not yet used for pediatric population. So in local anesthesia, can write the answers based on these headings. Another one, bacteriostatic with cidal antibiotics. So I hope you know the definition. Cidal antibiotics are those that kill the bacteria and static are those that inhibit the multiplication. Cidal has got irreversible actions. Static examples like tetracyclines, macrolides, chloramphenicol, clindamycin, ethambutol. Cidal, classical beta-lactams, penicillin, cephalosporins, aminoglycosides, fluoroquinolones, metronidazole. Some exceptions. Chloramphenicol is cidal at higher concentrations. Aminoglycosides, actually it is a cidal drug. Aminoglycoside like gentamicin, streptomycin, it is a static drug, it is a cidal drug. It becomes static at lower concentration. General rule, drugs whose mechanism of action is by inhibiting the cell wall or inhibiting the DNA are considered to be cidal. Protein synthesis, example, are static. Inhibiting the protein synthesis is static. One exception is aminoglycoside, which inhibits the protein synthesis, but it is cidal. So brief mechanism, you can just write down how they act. Clinical importance, when we use cidal in severe infections, life-threatening infections, rapidly dividing cells. So it is known that when we use cidal drugs together, it produce synergistic action. Static drugs together produce additive action. Cidal plus static may produce antagonism. It is possible, not always. Exception, doxycycline plus streptomycin in Brucella is synergistic. So these are the headings under which you can write the answer to this particular question. Classify antimicrobial agents based on the mechanism of action and write a note on beta-lactamase agents and metronidazole. So here just classify based on the mechanism. Drugs inhibiting the cell wall synthesis are bactericidal, cell membrane damage bactericidal, inhibiting protein synthesis mostly static. So under this bactericidal, you have the beta-lactams that bind to penicillin binding protein, inhibits the peptidoglycans and causes bactericidal actions. Colistin disrupts the gram-negative lipoprotein saccharides. Then bactericidal, you have vancomycin, phosphomycin. Then you have under static dose inhibiting 30S ribosomes, tetracycline, 50S ribosomes, macrolides, clindamycin. Ultimate is that it inhibiting the protein synthesis. Beta-lactamase, these are the enzyme produced by bacteria that lyse the beta-lactam ring and causes resistance. So we have beta-lactamase inhibitors like clavulanic acid, sulbactam, tazobactam. Okay, they are considered to be suicidal and progressive inhibitors. So you need to write what is suicidal means. They bind to the enzyme and they get disintegrated. And the inhibition goes on progressing as the binding increases. So suicidal and progressive inhibitors does not have any intrinsic antibacterial activity of its own except sulbactam. Combinations you can say like amoxicillin usually combined with clavulanic acid, ampicillin combined with the sulbactam, then piperacillin combined with tazobactam. Clinical points and dosage can be written down here. Metronidazole, a very commonly used antibiotic in dental practice because of its role in anaerobic infections. Dose, then acute necrotizing ulcerative gingivitis, pericoronitis, periodontitis, odontogenic infections, brain abscess of dental origin, adverse reactions like metallic taste and disulfiram reactions. That means these patients who are taking metronidazole consumes alcohol leads to reactions, peripheral neuropathy, dizziness, ataxia. Metronidazole is a gold standard for dental anaerobic infections. These are the points to be noted here. Pre-anesthetic medication for general anesthesia. So what is pre-anesthetic medication? The definition, you give some drugs before general anesthesia to make the general anesthesia more safe, pleasant, and less complication. There are seven A's or 7 aims of pre-anesthetic medication: to produce anxiolysis, to produce amnesia. The patient should not remember the events happening during the surgery. It should produce good analgesia. It should produce anti-secretory to produce, if you want to do an intubation, there should be no secretions. It should not produce vomiting, antiemetic. It should produce anti-autonomic actions, anticholinergic actions, and antacid. Aims that you need to write down. And based on this aims, which are the drugs that you use. So you need to write about anxiolytic agents, drugs like benzodiazepines. Amnesia, again, benzodiazepines are used. For analgesia, we use opioids, morphine-like agents. Okay, fentanyl can be used. Anti-secretory, we use anticholinergic agents. Antiemetics, we use metoclopramide-like agents. Then antacids, we use proton pump inhibitors. So those drugs can be just enumerated based on the heading. So midazolam can be used in child. In asthmatic patients, we use glycopyrrolate. Cardiac diseases, we use a combination of fentanyl plus midazolam. Intracranial surgeries, we use fentanyl plus glycopyrrolate. Recent trends is using a fentanyl, that is a opioid without much adverse reactions as compared to morphine combined with midazolam. Ideal pre-medication, midazolam plus glycopyrrolate plus ondansetron for elective dental GA. So that is about pre-anesthesia. Remember to write the aims and just elaborate the aims with the drugs that we use in pre-anesthetic medication. Status asthmaticus is nothing but a complication of bronchial asthma where it can be life-threatening and the patient is not responding to the usual beta-2 agonist and also the inhalational corticosteroids. Here we need to aware about the GINA guidelines. GINA guidelines is a global initiative for asthma where it has been stated that because of the anti-inflammatory property, we need to start inhalational corticosteroids at the start itself. So briefly write about the trigger factors, clinical features, immediate management to relieve the hypoxemia, bronchospasm. You start with oxygen, high flow oxygen, you give salbutamol, which is a short-acting beta agonist, plus ipratropium bromide, which is anticholinergic drug. You give systemic corticosteroids like hydrocortisone. Immediately IV is given. 100 milligrams is considered to be the drug of choice. IV fluids, maybe magnesium sulfate. So these are the drugs that are given initially in the first hour to control the hypoxemia and bronchospasm. More response, patient shifted to ICU, give IV beta agonist, IV aminophylline, adrenaline may be given IM or mechanical ventilations. Avoid sedatives, mucolytics, beta blockers, aspirin, NSAIDs, all will exacerbate asthma. So status asthmaticus, complication of bronchial asthma, enumerate the drugs used, say something about GINA guidelines. Okay. Epilepsy and its management. Now, epilepsy, it's a broader term. So you need to write what is epilepsy, what is seizure. Okay. Seizure is a sign or a symptom. Epilepsy is a disease. Okay. So seizure can occur in epilepsy and in other conditions also. Okay. Okay. So hyperpyrexia can lead to seizures. So that is not epilepsy. So that definition you can write. Anti-epileptic drugs you can classify based on the mechanism. Sodium channel blockers like phenytoin, carbamazepine, lamotrigine. GABA potentiation by benzodiazepines, calcium channel blockers like ethosuximide, gabapentin. SV2A binding, levetiracetam, carbonic anhydrase inhibitors like topiramate and zonisamide. So just the classification. Principles of management you can tell about the diagnosis, how you arrive on the diagnosis. Then you need to start the anti-epileptic treatment, choose the drug based on the seizure type. Then usually in 70% of cases, you give monotherapy or you give multiple therapies, go for liver function test, and then the drug has to be continued, sometimes lifelong, or the patient has a seizure-free interval of about 5 years. Then treatment of status epilepticus, similar to asthmaticus, it is a medical emergency where you give lorazepam as a drug of choice. For dental procedures, epilepsy need to be under well control on medication. Ensure patient takes the morning dose before going for the procedures. Proper history, morning dose of the epileptic drug and continue. Phenytoin has got an interaction with metronidazole that has to be noted, that increases the phenytoin toxicity. Local anesthesia is safe with minimum adrenaline. Paracetamol is safe. So that is about epilepsy. Broad spectrum antibiotics. They are the antimicrobial agents that are effective against gram-positive, gram-negative, rickettsial, chlamydia, mycoplasma, and all those agents. So we have examples like tetracycline, chloramphenicol, amino penicillins like ampicillin, amoxicillin, third and fourth generation cephalosporins, carbapenems like imipenem, meropenem, fluoroquinolones. So you can write down these names, the groups, you can write down the examples and the spectrum in short. And their indications, usually they are indicated for empirical therapy. Empirical therapy, you start the antibiotic without waiting for the culture sensitivity testings. Mixed infections, seriously ill patients, prophylaxis, dental, especially in severe spreading cellulitis and Ludwig's angina, where you give a combination of amoxicillin plus clavulanic plus metronidazole. Broad spectrum is usually reserved for serious unknown infections. So the disadvantage is that it can cause super infections, development of resistance and toxicity. And of course, these are a bit expensive also. So these were the questions that are commonly asked in the different type of university examinations. So I've just briefed about these. I know it's not complete. So these are the textbook. This is the one textbook that is usually referred, and I think that is enough. KD 3.9 edition. And if you have any questions, you can ask. Thank you.
Santosh. Any
Thank you.
questions?
No, ma'am. No questions.
Just check the chat box.
Okay, ma'am. No question, ma'am.
Thank you, Dr. Santosh, for that insightful session on pharmacology.
Thank you. Thank you. Thank you, ma'am.
Thank you, sir. Kindly accept the certificate as a token of our sincere gratitude for your informative and inspiring talk. Thank you, sir.
Thank you, Dr. Kavya. Thank you, Dr. Anjana, and everyone. Thank you for the opportunity.
Thank you so very much, Dr.
Thank you,
Santosh.
sir.
It was a wonderful lecture. It was
Thank you so
such
much.
a easy delivery of words that I'm sure the student must have taken tips and noted the points. It was amazing lecture.
Thank you. Thank you so much, sir. Thank
So
you.
there's
Thanks
one
a lot.
question. Can you please explain how to calculate the drug dosages?
Madam, actually, there are different formulas that were used previously, but as of now, based on the adult dose, like for amoxicillin, we calculate as 20 to 40 milligrams per kg. So if you have a pediatric patient, just note the weight, and based on this, milligrams per kg per day. So that is the actual
Multiply.
situation that is.
Yes. Thank you, sir.
Yes. Thank you. Thank you.
Now it's time for lunch break. Kindly reassemble by 2 p.m. for afternoon session.
Thank you all. We'll reassemble at 2 for the second session for today. Thank you.